Please don't go away. There's still one more session. The picture was taken to compare with the picture which is going to be taken after this session to know how many of you went away. I hope so. So we are starting with the new next session, are we? Okay.
Okay. All right. So we start with the next segment, that is the refractive surgery segment, and this is the part one. And I invite our chair, Dr. Rupal Shah ma'am, and Dr. Pranita Sahai to join on this stage. And Dr. Rupal Shah is the director of New Vision Laser Centers. Is that right, ma'am?
Now
right?
Center for Sight.
Now Center for Sight, Vadodara, Gujarat. And Pranita, she is the associate consultant and cornea, cataract and refractive surgery at CFS Delhi. And she is one of the most vibrant teachers, and you've already met her in the hands-on course. You had a very dedicated session with her. So over to her on the workup of a refractive surgery patient and decision making.
Thank you, Rolika, for the introduction. I know you must all be very exhausted by now, but so many extensive lectures. So, good evening, everyone. I'm Dr. Pranita Sahai, and I'll be discussing about an important topic, that is how to work up a patient for refractive surgery and how to decide which surgery is best for your patient. So first, the patient workup, it has three components. First being history taking, then the clinical examination, and lastly, the investigations. So when you take a history, a medical history is really important. First, you want to know the patient's age. You know that it is surgeries are approved for above age of 21. However, below 18, you do not want to operate these patients. And any patient around the age of 38 and 40, you know, is around presbyopic, so you want to be sure of their age and their refraction. You want to also know about their use of glasses, how long have they been using it, how good compliance they have, and when was the last change of their power that they had to know the stability of their refraction. Also, if they are a contact lens user, whether they are using a soft or a hard contact lens, and when did they last use a contact lens, because that will alter your time of assessment of the patient, because sometimes contact lens use can alter your corneal curvature and contour. Lastly, you also want to assess what is the patient's expectation out of surgery, whether they have realistic expectations or out of the world expectations. Some patients will come to you that I have a headache with the use of glasses, and that's why I want to get rid of the glasses. Then you need to counsel them that is not the purpose of surgery. Somebody who wants to go ahead for a cosmetic removal of glasses, they are the best patients. Some people want to go ahead for a job requirement, they want to go for a removal of glasses. You need to explain them that 6'6" is not something you can be 100% sure. Sometimes the patients can also be 6'9", and you need to explain these things well before ahead. So in ocular history, you want to know any past history of hepatic infections, because they can undergo reactivation post-surgery, any prior refractive surgery, squint surgery, any associated ocular comorbidity of uveitis and glaucoma, or use of lubricants, as use of lubricants can also mask the presence of dryness that these patients can have, most of which are relative contraindications that we just mentioned. Now, moving on to the systemic history, there are certain conditions that alter the eye's wound healing process post-surgery, hence diabetes mellitus, autoimmune diseases, collagen vascular diseases, and keloids. These are relative contraindication for corneal-based refractive surgery, especially PRK, as wound healing is really important in these patients. Pregnancy, lactation, and hormone therapy, or both these conditions are known to fluctuate the patient's refractive error. Hence, you should usually avoid operating these patients and ask these patients to follow up after they have discontinued lactation, so that you can give a good refractive outcome to these patients. Certain drugs used for migraine, acne, and antihistaminic drugs are known to cause dry eye, hence should be discontinued before surgery if possible. Also, you need to know about the patient's profession, if is involved working in army, wherein ocular trauma is very common, or is involved in contact sports. These can alter your decision for refractive surgery in these patients. You will obviously not want to do a flap-based procedure, as they can have long-term complications related to the flap due to trauma. Now, moving on from history taking to the clinical examination, what is important is to document the visual acuity monocular, both uncorrected as well as the corrected, distance visual acuity as well as the near vision. Now, the Snellen's chart is something that we routinely use in our OPD, but an ETDRS chart would be ideal, as the objective documentation of the vision per letter can be well documented on these charts. After you have documented the vision, you want to know the patient's refraction. You go for a dry refraction followed by a cycloplegic refraction. Cycloplegic under a tropicamide is usually enough, but for patients who are hyperopes or have low myopia, can be showing high accommodation and can be pseudomyopes, you would also like to use hometropin in these patients. Then you move on to phosimetry or a lensometer testing, wherein you want to estimate the power of the glass so as to assess the stability of refraction. A plus minus 0.5 diopter change over 1 year is acceptable. Following this, you also want to assess the patient's intraocular pressure and the near point of convergence. Near point of convergence is important because most of these myope patients usually have convergence insufficiency, and hence post-refractive surgery, a lot of patients come with complaints of difficulty in reading for near. So if you do a near point of convergence pre-op and you diagnose convergence insufficiency, you can pre-operatively advise them for convergence exercises, and hence these patients will not have such problems post-operatively. After this has been done, you want to do an eye examination, but rather than jumping on directly onto slit lamp examination, you should do a proper torchlight examination of the external eye. You want to look for the lid position for any ptosis, for the position of the eye for tropias, for a cover test to look for any fovea, and also ocular motility test and orbital anatomy. Orbit anatomy assessment is very important because sometimes the patients have deep set eye, and when you're planning a patient for a femtosecond laser based procedure wherein docking of the eye is done to docking of the eye for suction achievement and following by the delivery of femtosecond laser, the docking becomes difficult in deep set eyes, narrow palpebral aperture. You can have suction losses, hence you may plan them for only an excimer based ablation, that is a PRK procedure. Now moving on to slit lamp examination, not just the examination of cornea is important, but assessment right from the tear film height to assessment of the lid margin for MGD, conjunctiva for papillae assessment, cornea for scars and vascularization, anterior chamber depth important for patients when you're planning for a phakic IOL, lens for any early nuclear sclerosis changes, because you know any nuclear sclerosis that is bound to progress, and refractive surgery may not give optimal outcomes. Patient may develop refractive error soon after surgery. A fundus examination within 90D to assess the optic disc is also important. So what we learn is any papillae allergic conjunctivitis patient can develop dry eye, post-op exacerbation, so you want to treat allergies before you operate them. MGDs, you know, are very common in these days, and if present preoperatively needs to be treated, they can be risk for post-op infection as well as DLKs. Moving on to clinical examination, you know the most important complication that patients post-refractive surgery face is dry eye. Hence, you want to do a proper dry eye workup wherein you will do a ocular surface staining with the Schirmers to assess the TBUT and look for any corneal staining. Then you will do a Schirmer test, and other tests like tear osmolarity, NIBUT, and meibography, if available, can be done, but mostly tests are limited to TBUT, staining, and Schirmers. A dilated fundus screening is very important in myopes because you know degenerative changes in the retina are common. If there are any such changes, you may want to do a laser of the degenerative changes if there is a risk for a retinal detachment in long run because of those changes. With that, you complete your clinical examination, and next you move on to investigation. As you all know, the most important investigation for any patient undergoing refractive surgery is corneal topography. Pentacam is the gold standard test. We have already discussed in detail in the hands-on training how to read a pentacam. So the two most important maps that you need to look at before planning the patient for surgery is the 4-quad map and the Bellin-Ambrosio enhanced ectasia display. You want to rule out any ectasia or form frustrated keratoconus because you don't want to operate on any such patients of FF cases, or a topography which is borderline, which may develop ectasia in the long run, because that is one of the other dreaded complication that can happen in the long run if you don't screen patients well. The next important thing is pupillometry. You need to understand that all refractive surgeries wherein we are treating the cornea with lasers is in the central 6 to 6.5 millimeter. You don't treat the entire cornea. Hence, if the pupil diameter is more than 5 millimeter, glare, halos, and nighttime vision disturbance is bound to happen in these patients. Hence, pupil assessment with whatever investigative tool that you have, whether with Pentacam or VKG, you can do it, and you need to screen. If it's more than 5 millimeter, patient is not a suitable candidate for refractive surgery. These are the topography parameters or screening parameters we discussed in the hands-on as well, that you need to look at in the 4-quad map to rule out early cases of FFKC or abnormal topography in which you do not want to operate. You may want to reassess in 6 months for a stability of the topography before you intervene. Similarly, in the bad map, we also have these parameters. I'll not go into these. These are basically theoretical to remember. Now, moving on to the next investigation, which is the most talked about these days, is the corneal biomechanics. Earlier, it was the ocular response analyzer. Recently, it is the Corvus ST, which is the ocular biomechanical assessment coupled up with the Pentacam. So in these, there are certain parameters, again, which can help you in diagnosing patients which are at risk of developing ectasia in long run, in which you do not want to operate. Contrast sensitivity is known to decrease post-refractive surgery. Hence, some surgeons like to document the contrast sensitivity preoperatively, but it is not routinely done always. Wavefront analysis, if for higher order aberrations, if you have the facility to test, is good because it can help you in planning the best refractive surgery for your patient. So with this, we complete the patient workup from history to clinical examination and investigation. Now we'll move on to the most important thing, is to decide which refractive is the patient suitable for refractive surgery, and if so, which is the best procedure. So before we move on to that, a basic overview of the types of refractive surgery that are available. So refractive surgery, as you all know, can be either cornea-based, lens-based, or a combination of the two, which is referred to as bioptics. While incisional-based refractive, cornea-based refractive surgery is only of historical interest now, it's predominantly now limited to laser-based procedures, wherein PRK, LASIK, and SMILE are the three most commonly performed surgeries. In lens-based surgery, you all must have heard about phakic IOLs. Refractive lens exchange is now put into limited use and was used only in the past. Now, laser-based refractive surgery for corneas can again be divided into excimer, femtosecond, or a combination of the two. As you all know, SMILE uses only femtosecond laser, while femtosecond LASIK uses a combination of the two, and PRK uses only excimer laser. Now, the FDA-approved ranges for these procedures also needs to be learned up. It can be asked up in your vivas. For surface ablation and LASIK, from +4 to -10 is the accepted range with 4 diopters of astigmatism, while for SMILE, it varies from -1 to -10 and a cylinder up to 3 diopters. Phakic IOLs can be used from +3 to +10 and -3 to -20 with up to 6 diopters of astigmatism. Now, moving on to the two important questions that we discussed. Who is the suitable candidate for refractive surgery? So an ideal patient is one who's above 21, has a stable refraction for 1 year, not pregnant or lactating, no systemic or autoimmune disease, and is adequately counseled and has realistic expectations of the surgery. Contraindication, most of these we covered in the clinical examination and history taking. You do not want to operate on any patient with unstable refraction, dry eyes, ectasia, uveitis, herpetic infections, large pupils, glaucomas. Systemic, pregnancy, lactation, autoimmune diseases need to be ruled out. Drugs we've already covered. Now, all efforts are towards avoiding a risk of post-operative ectasia. Hence, few scoring systems have been developed to pre-operatively screen these patients for risk of post-operative ectasia. One of them is the Randleman ectasia risk scoring system, and the other one is the which is given by the Massachusetts Eye and Ear Infirmary. Both these use a combination of parameters taken up from the topography, patient's refraction, and patient's corneal thickness, based on which you can pre-operatively assess the risk of post-op ectasia. So now we'll move on to some case scenarios. This is a 25-year-old female who wants a refractive surgery for cosmesis, has stable refraction. Myopia is minus 1.5 with 0.25 with minus 2.5 cylinder, and a pachymetry of 461,504. So this should ring a bell in your mind. You have a thin cornea, high cylinder. You want to look at the topography. If you look at the topography, the sagittal curvature map is showing you that there's an asymmetric bow tie pattern with skewing, although the keratometry is not too steep. But if you look at the pachymetry, cornea is thin with the decentration of the thinnest pachymetry. Also, the posterior elevation is high. Hence, this is not a normal topography, and you do not want to do a cornea-based refractive surgery in this patient. So now with surgery, now you know which one is not a suitable candidate for a cornea-based surgery. But now when you have selected the patient that, okay, this is a suitable patient, which surgery is the next important question. So before we move on to the types of surgery, there are certain cutoff parameters that you need to remember which are important for planning a cornea-based refractive surgery. The first one being RSBT, that is the residual stromal bed thickness. So how is it calculated? It is calculated by subtracting the flap thickness and the ablation depth from the central corneal thickness. And how do you know what the flap thickness is? So on an average, you can know that is around 100 to 110 microns. And ablation depth is the amount of cornea that you're going to burn in the excimer laser, or the thickness of the lenticule that you're trying to remove in SMILE surgery. How do you calculate that? For that, you have a formula, that's the Munnerlin formula, which is calculated by refractive error into the optical zone square divided by 3. To simplify it, this comes to an overall figure of around 13 to 14 microns per diopter. So that is how you will calculate the residual stromal bed thickness. A cutoff of 280 micron is wise, and that is most commonly used by most surgeons. The RSBT should be more than 280. If it is less than that, you're weakening the cornea too much and can put the patient at risk of ectasia. The second important concept is the percentage tissue altered, which was given by Santiago et al., which is calculated by the flap thickness plus the ablation depth divided by the corneal thickness. And this parameter, if is about 40%, that means again, you're altering the cornea too much and the patient is at risk of ectasia. So we want the figure to be less than 40%. The third parameter is keratometry, that is the post-op expected keratometry. In myopia, you are flattening the cornea, while in hyperopia, you're steepening the cornea with lasers. So what is the expected post-op keratometry is 34 to 48 diopters. Anything going less or above this, you are altering the cornea too much and will induce a lot of optical aberrations, and the quality of vision is going to go down. So how do you calculate this? So in myopia, you have a 0.8 diopter flattening per diopter of refractive error that you treat, while in hyperopia, there is a steepening of around 1 diopter per diopter that you're treating. Now, there are certain criteria for ICL or phakic IOLs that also you need to remember. The most important of it is the anterior chamber depth. If the anterior chamber depth is less than 2.8, the chamber is too shallow, not a good candidate for phakic IOL. You can put the patient at risk of glaucoma because of angle crowding. And also the white to white, if is less than 10.8 or more than 13, your phakic IOL is going to be unstable in these patients. Hence, these are the two important parameters for phakic IOLs. So now for refractive surgery, if the RSBT is more than 280, PTA less than 40%, and post-op expected keratometry in the range of 34 to 48, cornea-based procedure is going to be ideal. But if these parameters are not based, you want to plan the patient for a lens-based procedure for optimal outcomes. So now we have some case scenarios, and I want you to answer these questions. You have a 24-year-old male, has a stable refraction and refractive correction, wants refractive correction for cosmesis, has moderate myopia, -4, with 1 diopter SIL, a normal topography, a good corneal thickness, RSBT, residual KM, PTA, all are normal. What do you want to do, a cornea-based surgery or a lens-based? So, right, you want to do a cornea-based procedure, which can be either LASIK, SMILE or PRK, that will come to next. So, in cornea-based surgery, you have 3 options. One is PRK. When do you want to do that? Patients with very low refractive errors, you can go for PRK. With high refractive errors but thin cornea, you want to alter the cornea less. You want to preserve the maximum thickness. Thirdly, patients who are predisposed to trauma, for example, patients who want to go for army, who are in contact sports, and patients with recurrent corneal erosion syndromes. These are ideal for PRK. LASIK and SMILE can be done in all categories, low, moderate, high myopias. What is different is the patients who are in contact sports or planning for army, who are at risk for having ocular traumas or have mild dry eye. In these situations, SMILE is going to give you an edge over LASIK because it's going to be flapless, and also dry eye is known to be less in SMILE patients. Again, next case scenario, so you have to answer. It's a 21-year-old male applying for the armed forces, low myopia, refractive error of minus 1.5, 0.25 SIL, normal topography, normal RSBT, PTA, and post-op KM. Which surgery do you want to do? Cornea-based, lens-based? Which one? PRK, LASIK, or SMILE? So you can do either SMILE or PRK because it's a low myopia. You can even consider for PRK. Now, next case scenario. There's a 25-year-old male, wants refractive surgery for cosmesis, is a football player, moderate myopia, normal pentacam, normal cutoff parameters for cornea-based surgery. Which cornea-based procedure? SMILE. Okay, now this is a moderate myopia. PRK, you know, as the refractive error increases, there is a little risk of post-op corneal haze. So definitely a SMILE will give you a better result in this patient. Now third, this one, 23-year-old female, refractive surgery for cosmesis, refractive error -3, -4, Schirmers of 6 and 7. Okay, so first what you would like to do is start on lubricant, cyclosporin, okay, stabilize the ocular surface, reassess in 6 months, and then definitely SMILE is something that you will counsel the patient for. Now you have a 21-year-old female for cosmesis, removal of glasses. Now the power is in pure cylinders, -3.5. The pentacam, obviously you need to be cautious, showing a regular astigmatism, rest everything seems to be normal. If you look at the corneal cutoff parameters are normal. Which procedure do you want to plan for? Why do you want to plan for LASIK? Okay, the patient has high cylindrical power, so if the cylindrical power cutoff accepted range and also approved by FDA is up to 3 for SMILE, and the results of LASIK and PRK can be better, especially for patients who have high cylindrical power. Now, how do you optimize the outcomes of LASIK in patients who have higher order aberrations? So the higher order aberrations of less than 0.3, you can go for wavefront optimized LASIK, wherein you do not induce any new aberration. But if the pre-existing higher order aberration is more than 0.3, you want to plan the patient for wavefront guided LASIK or a topography guided LASIK, which is most commonly known as the Contura LASIK technology. Because with this, you can also treat the pre-existing HOAs that these patients can have and can give you a good quality of vision post-operatively. So with that, we finished the cornea-based surgeries. Now moving on to lens-based surgery, you can have either phakic IOLs, refractive lens exchange, or bioptics. Now phakic IOLs is suitable in all patients who have high myopia and clear lens, okay? And cutoffs that we discussed, an AC depth of more than 2.8. Refractive lens exchange only and only when the patient has early changes of nuclear sclerosis. Previously, it was used in patients of very high myopes, but now even customized lenses with the IPCL are available for myopia even as high as -25, 26. So refractive lens exchange is no more done for these patients. Bioptics, when these customized lenses were not available, then obviously phakic IOLs like ICL was combined with cornea-based procedures because ICL, you know, can treat only up to 16 diopters of myopia. Anything over and above, you would require an additional procedure to treat the residual refractive error. So now another case scenario. You have a 21-year-old male wants refractive surgery for cosmesis, high myopia, -10, -9, and unfortunately the corneal thickness is not too good, so corneal cutoff parameters are not met. So which procedure do you want to do? You want to do a phakic IOL for this patient, and ICL can be one of the options. Now another 21-year-old male wants correction for cosmesis, minus 18.5, minus 16.5. Topography not supporting, corneal cutoff not met. Which procedure do you want to do? Yes, so here you would like to look at the AC depth first, if it is adequate, IPCL or bioptics, that wherein you can combine ICL with PRK in these patients. The third case scenario, 34-year-old female, minus 10, 2 diopter SIL, normal looping topography, but not the corneal cutoff parameters not met. Endo AC depth is 2.7 and 2.73. What do? You do nothing. You counsel the patient against refractive surgery, and if at all the patient is highly motivated, you can advise them for a refractive lens exchange with a multifocal IOL or an EDOF IOL if the patient is highly motivated, because the patient is 34. Okay? So with that, we'll conclude this discussion on decision making. I hope I made my points a little clear. Thank you.
Thank you, Pranita. That was really, really complete. I don't think there would be any questions.
Anybody wants to change their options for the polished apple, they're most welcome to do so. Right? So that was a perfectly timed and perfectly articulated talk by Pranita. And I now request Rupal Shah ma'am to take over. And ma'am, would you cover both the talks together? So ma'am will be first taking up her talk on step-by-step LASIK, basics of excimer ablation, followed by surface ablation. I request Dr. Pranita to please come up as chair.
Good evening. It's really heartening to see still so many of you here. So I would just start by giving you a little mantra of happiness. Some really intelligent and thinker of the world has said that if you want to be happy for a few seconds, then indulge in a chocolate. I think some of you got the privilege in the last session. If you want to be really happy for a few minutes, then listen to a song. If you want to be happy for a few hours, read a nice book, go for a movie. If you want to be happy for a whole day, go for a picnic. If you want to be happy for a few days, take a vacation. If you want to be happy for a few months, find a girlfriend or a boyfriend. But if you want to be happy for a few years, do get married. At least for a few years, it gives you happiness. But if you want to be happy for a whole lifetime, then learn to be happy with what you are doing. And that passion I'm seeing here, and I'm sure you're going to be happy. Otherwise, you all won't be here sitting in the last session, still so enthusiastic and still able to smile. And that's what is going to make you all happy. That's the secret that Dr. Santosh Unnawar, Dr. Rashmin, Dr. Rolika here, Ritika, Dr. Maipal, all have found. And that's why they are happy. Thank you very much. I think we'll go back to our topic, the basics of excimer ablation. And it was really nice. You made a really nice base on which I can go ahead.
Thank you, ma'am.
So you would be surprised to know that it was way back in 1950 that such attempts were made on the cornea, polishing it in order to get rid of glasses. So right from the moment glasses were there, people were trying to get rid of them. And some of you here must be really thinking that those attempts were really essential, because you, I can see, are dependent on glasses. But as you know, cornea, if handled not well, can lead to scarring. So these initial attempts, of course, were very crude and they failed. So when lasers came into being, people thought that now they had a solution. So several different lasers were tried. The ones worth mentioning are the picosecond YAG laser, which was used for its photo disruption to create incision and excision. Carbon dioxide laser was used for a while for laser thermokeratoplasty. And holmium laser I have also seen getting used, so of course not so long back. And it was used for creating burns on the cornea at the mid-peripheral level around the pupil so that it would cause collagen shrinkage, which would form like a purse string effect. Since you have at the mid-periphery a purse string effect, you would have the center to be steepening slightly, which would give you little correction for hyperopia as well as presbyopic correction. All these attempts failed because they suffered from imprecision, they suffered from lack of control, and the collateral thermal damage that was happening was simply not acceptable. And therefore, when excimer lasers came into being, there was a wave of excitement that followed. And this was because of the very special properties of excimer laser, that when an excimer laser falls on any tissue, the tissue simply melts away. It acts by a process called photoablation. Do you know what photoablation is? Anybody? No chocolate for guessing, but if somebody can tell me. What happens to a tissue when such laser hits a tissue is that the intermolecular bonds between cells break. So those cells no longer exist there, they get evaporated. And can anybody tell me what is the wavelength of an excimer laser? So it's in the ultraviolet range. So anything that is firing in the ultraviolet range, we know that we are afraid of sunlight, getting exposed to sunlight so much. And now you are directing the ultraviolet light into the cornea and doing a procedure. Aren't you afraid of mutagenicity and carcinogenicity? That would be the first question that comes to your mind, right? But here, this particular wavelength is such that it is getting absorbed totally in the cytoplasm of the cell, and it leaves the nucleus alone. This is known as the nuclear shielding effect of this particular wavelength, and that's why we can use it in human body without causing any such mutagenicity or carcinogenicity. So they are safe lasers to use, and it's been proven now for more than 30 years. The first excimer laser procedures that were done in the world were in 1986-87. So way back, we know now that the tissue interaction with the human body is absolutely safe. There is no collateral damage. The trench which is caused is smooth and etched, leaving behind an absolutely smooth surface. And today, if you ask me, it's very simple and very easy to control the shape and pattern of tissue removal. This is how predictable the excision of the tissue is. And if you can see, the next cell which is next to that incision is as normal as anything beyond it. So there is no collateral damage, leaving behind an electronically smooth surface. And this is what human tissue this is. Anybody can tell me? It's a human hair. So you can actually make patterns on a human hair with this precision. So it works at micron level specificity. What is an excimer laser? It's an excited dimer of a noble gas and a halogen. So it can come in the form of an argon fluoride, where argon is the noble gas, the fluoride is the halogen component, which fires at the 193 nanometers, which is the common excimer laser that is getting used. It can come in the form of krypton chloride or xenon chloride also. It's a so-called cold laser. So it is not actually cold to touch. If you put your hand underneath, you do feel it, but because it is not causing any thermal effect on the corneal tissue, it is known as a cold laser. The penetration depth is limited to few microns, typically about 2 to 3, leaving behind a very smooth surface. The ophthalmic excimer laser is the argon fluoride 193 nanometers. Argon and fluorine combine under a very high voltage spark, around 30 kilovolts, to form an argon fluoride plus dimer. It is in the excited state, and this molecule is not stable. So it goes back to its normal state of argon and fluorine gas, releasing the 193 nanometer radiation, and that's the excimer laser that we are using. So you need a laser head which contains the mixture of argon and fluorine. Across the laser head, there are electrodes which are connected to a capacitor bank. you need a very high voltage power supply, which can generate a 30 kV pulse, which is given for very few seconds, nanoseconds. And this discharge causes conditions which force a reaction between the argon and fluorine. So there are technical complexities. You need a very precise switch. You need a very high voltage supply and a laser head which is capable of long gas life and a sufficient frequency. And there are then added complexities due to the beam delivery system. The basic components of an excimer laser system, that's why it's quite complex. You would have a gas supply, you would have a laser head, electronic controls, and a whole big delivery system with number of optics on the way, because an excimer laser needs to be firing close to where you need to work on. And therefore, you need a delivery system also, which is going to give you an absolutely precise outcome. So there are a number of scanning lasers, and therefore you have to be very, very careful when you're using an excimer laser. Your excimer laser needs to be maintained very well. If it is not maintained well, your precision in the refractive outcome would not be there. You also need a very precise environmental condition, because an excimer laser can get affected by the humidity in the environment, it can get affected by all the vapors in the environment, and at the depth at which it is working on the cornea, the humidity in the cornea, and therefore everything needs to be absolutely perfectly maintained in order to get the perfect result. And therefore femtosecond based procedures did come into being and also gave a much precise outcome. And I would just differ a little bit, Pranila, that the pure cylindrical error treatments are also possible with just a 0.5 diopter of spherical error in a SMILE procedure. And also, you should not go by everything that the FDA has approved. Especially in the field of refractive surgery, USA lags behind a lot in front of all the developments that occur in the world. In 1994, when we first started doing excimer laser treatment, I was I think the third in India to get my excimer laser, and the US FDA approval happened and went to an excimer laser in 95, that to a -6 diopter broad beam laser, pure spherical error treatments, when we were treating already cylinders and were on to treating hyperopic treatments. So US FDA is really lagging behind. Same thing happened with the SMILE procedure. In 2006, there were 250 eyes done in Germany. In India, we had this opportunity to do it in Vadodara, the next 1,000 eyes, which made it possible to be released commercially in the world. So India, in fact, was at the forefront of development of SMILE procedure, and US FDA approval went through in 2011, so far back. And that too, we had done 250 eyes and given as our contribution to accelerate the procedure for SMILE approval in the US. So not everything that gets approved in the US is what gets followed in the world. Europe has always been at the forefront, and India has not lagged behind in development of refractive surgeries. I will continue with my next talk and cover up in the time. So all lasers need, so the myth is that all lasers need optics and gas change. There are solid state lasers which don't use gas, but it is not truly an excimer laser, it only has an excimer-like wavelength. There's nothing like a LASIK laser. LASIK is a procedure. The laser, LASIK can be done by all types of lasers, including a solid state laser. So there is no LASIK laser as such, and there is no exposure to poisonous gases. There are no poisonous gases. They are not leaking into the environment, and even if you are yourself pregnant, or by mistake you have operated on a pregnant lady, you can still have no side effects of an excimer laser, because the penetration depth of an excimer laser is only few microns. So you as a pregnant person can also operate. I've operated till the last date of both my kids' deliveries. Spot scanning lasers are the ones which are used today. There are laser apertures with a small fixed diameter beam which moves with computer control to create round or elliptical ablations. And the advantage is that it leaves behind a very smooth cornea and can create even relatively arbitrary patterns. The disadvantage is that it requires a really good eye tracking system, and faster scanning can heat up the cornea. Whenever an excimer laser hits the cornea, there's a mushroom cloud, and it needs to be taken away, and therefore there are plume evacuation systems which are present in most of the lasers, along with a very fine eye tracking systems. You also need correct energy in the periphery, and this is very well adjusted in normal lasers. And all modern lasers have some form of adjusting for this peripheral loss of energy. This is an important concept to understand. When an energy falls in the center, it is as a round. So all the energy is incident in that round. But when it falls in the periphery, it's an oval. Also, because it falls at an angle, there are some Fresnel reflection losses. And therefore, the lens that you would create would be oblate as compared to the prolate cornea that you were initially dealing with. This can lead to higher order spherical aberrations leading to night vision issues. This was recognized long time back, and most modern lasers either give higher energy shots at the periphery or give extra energy shots at the periphery, and therefore you can retain the prolacity of the laser, of the lens that you create. This is known by different names. It's known as aberration smart ablation. It's also known as wavefront guided or wavefront optimized treatment. It's known as aspherical ablation, and this is a part and parcel of most modern lasers to maintain the natural shape of the cornea. So basic key to refractive surgery is corneal reshaping, and this is because it contributes to 2/3 of the refraction of the eye, and we can then make smaller changes on the corneal surface to go a big way. You can flatten to create myopia, but to do a hyperopic correction, you need to treat the mid-periphery, so that compared to the mid-peripheral flattening, you get a steepening in the center. Also, there is something which is known as a coupling effect, which leads to a steepened area right next to a flattened area. And this is how you'll be able to correct hyperopia. The 3 techniques of corneal reshaping is PRK in all its, or a surface ablation in all its different forms. LASIK, which is intrastromal ablation, which could be bladeless, where you make the flap with a laser, or it could be with a plate, where you use a microkeratome-like device to create a flap. And SMILE, which is the new blue-eyed boy, which is lenticular extraction. So we go on to our next talk, which is photorefractive keratectomy or PRK. Here, as you know, in the cornea, we are making a reshape. Now, if you want that shape to be retained, you can't go through the epithelium, because if you are going through the epithelium, you would have the epithelium reforming, and all the shape change that you make will go away. So somehow you need to go underneath the epithelium, and therefore one way to do it is to do a surface ablation. In surface ablation, the surface epithelium is removed either mechanically, then it is known as photorefractive keratectomy or PRK. If you use alcohol to assist the removal of the epithelium, it is known as LASEK with an E. If you use a microkeratome-like device, then it is known as LASIK, because you create, using a very blunt knife or a blunt blade, you create just an epithelial flap. And if you use a laser to remove the epithelium, it's known as transepithelial PRK. And these are all forms of epithelium removal. In all the forms, you would need the epithelium to reform. So all these procedures almost behave the same way. Only the way you remove the epithelium is different. In transepithelial, because you are not going beyond the margins, you may have little earlier reepithelialization, but ultimately the results are the same. You also need to treat all these cases the same way. As there are some people who believe only in surface ablation, some believe only in LASIK, some believe only in SMILE, but there is definitely a need for balance, because you all should know that every technique has its own place, its own indications, and used properly, you can give the most benefit to your patient. A PRK should be done for any myopia less than -6 to +3, I would say, is the new norm. Where the cornea is thin, where there is a danger that you would be thinning the cornea too much, where no trace of the surgery is to be allowed, where the patient requires no touch technique because they are afraid of a flap or even a cap, and when the patient wants no chances with the flap but can't afford a SMILE. When there are very small eyes, when there are pterygium, when you are a totally novice LASIK surgeon, somebody needs it for career purpose, you want to be sure to do a good job, and when there exists epithelial dystrophy with loose epithelium, then PRK is the procedure of choice. But your patient should know that recovery is going to be slower than after LASIK, that there would be substantial pain in the first 24 hours, and that they should be coming for a regular follow-up because they would need to use steroids for the wound healing response to be regulated post-operatively. When PRK should definitely not be done? In people who are likely to have great sun exposure, in very high refractive error corrections, in patients who are diabetic, in expectant mothers, in patients who have oral contraceptive pills, who have PCOD, patients preoperatively, it's all been very nicely talked about in the previous lecture. The anesthetic used here is copious because we want the epithelium to become loose. And you also need to use NSAID, which would help in the post-operative period too. You need to use the same. Surgical steps are very simple as compared to LASIK because you just need to remove the epithelium in one of the ways I described, run the laser, and allow the wash with chilled BSS. Now, this is a very important component for pain management post-operatively. There are important things that have come into picture, that if you use chilled BSS, if you use a NSAID-soaked BCL, if you use a very cold BCL post-operatively, and if you use the correct systemic medication, then pain can be controlled very well, and most people are quite comfortable. Today, if you ask me, reepithelialization in a 7 millimeter zone occurs within 2.5 days, and patient can be quite comfortable even in a surface procedure, so should be taken into account as a primary choice for the indications that have been pointed out. You also need to be making sure that the patient follows the post-op steroid regime properly, and that vitamin D levels play a big role in the post-op healing. So you should be getting the vitamin D checked beforehand, and if they are not in normal zone, should be got back into normal. Surgical steps are very simple. I'll just demonstrate them to you. You can mark the area in which you need to remove the epithelium. And you can very easily use a blunt knife, like a Tux knife, to remove the epithelium. You should just make sure that epithelium removal happens fast, and at the end you are leaving behind a very smooth surface. Like this. When you are beginning your laser, you should have a smooth surface like this with no tears or in the Bowman's membrane. This is the excimer laser, which is working on that smooth bed that you created, and this is followed by dripping Bell salt solution. In very high treatments, you could even use mitomycin C. In very small treatment, you may avoid using mitomycin C. Post-operatively, you may require, if it's only one eye, a patching would be okay, but with both eyes, you would require bandage contact lens. Monitor the epithelium healing. start steroids as quickly as possible. And once epithelium has healed, you can start with fluoromethalone eye drops. Depending upon how much depth you have treated, you can titrate it and also use it for 2 months, 3 months, or 4 months in a titrating dose, in a tapering dose. You should look for rise in the intraocular pressure. So use beta blockers or taper steroid faster. What are you expecting as a typical vision recovery? On the first day, over the BCL, they can see enough to do and most of their activities. In about a week's time, the refraction is about +1, 1.5, but most are young patients, they can accommodate. So if your refraction is little on the plus side, don't worry in the first month, because the epithelium is not full thickness yet, and you would show a hyperopic shift. But at 3 months, everything settles down. The complications can be epithelial healing response. It could be related to wound healing response, and it could be related to the steroids that you give. In epithelium healing, sometimes it causes delayed healing. Sometimes there is filamentary keratitis, and sometimes you require to give a lot of lubrication to aid the epithelial healing response. You can sometimes have over or under correction if the wound healing response is not correct. In this case, by titrating the steroids, you would be able to help the wound healing response. And if decentrations today are very rare because your eye tracking systems are working very well. Sometimes you see haze, which is an integral part of a wound healing response. You see sometimes also epithelial iron dots like this, which are of no consequences, but you would know if you see a patient later on that something like this must have happened in this eye. I would just talk briefly about the haze. Haze should be tackled because if haze occurs, it can deteriorate the quantity and quality of vision. Haze is something that can occur because of non-compliance to steroid drops or because of an aggressive wound healing response where the keratocytes are activated to a great extent. There are certain eyes which are prone to haze, and this you cannot really judge from in the preoperative stage. Therefore, a close observation in these patients are absolutely mandatory. Anything more than grade 1 haze at 1 month, you should step up on your steroids. Also, you can give antimetabolites. And if you are treating very high myopia, you should use mitomycin C right in the beginning. Haze over a period of time can go away, but regression which is associated with haze would persist. Retreating a haze with PTK does not really help because activation of keratocytes would occur again and you can get haze again. Thank you very much.
Thank you, ma'am, for the wonderful talk and the comprehensive details that you gave us. Thank you, ma'am.
Thank you, ma'am. Your second talk is done. So we move on to, please continue as our chairs, please. So we move on to the next segment, and that is refractive surgery 2. And I request Dr. Chitra Ramamurthy ma'am to please join us. Mahipal sir will be joining us very soon. So till then, Chitra ma'am will be covering the topic topo-guided treatments in normal and abnormal corneas.
आएंगे आप?
Excuse me.
Very good evening to one and all of you. I'll try my best to not to make it dreary for you all. This is a totally new component for you all. But I do believe that if you are a DNB candidate, anything, any question, anything can come up. So it's better to be informed to, in some way, what I'm going to try to talk to you. So basically, earlier talks were about surface ablation. Basically, we understand that excimer laser creates an ablation profile on the cornea, wherein it reshapes the cornea. So that much you all have understood. Okay? So in this treatment profile or the ablation pattern which does on the cornea, there are different patterns of doing it. It could be a wavefront optimized, it could be a wavefront guided, or a topo guided, or it is something a surgeon has the ability to customize the treatment based on the shape of the cornea, which is less often done. So then, I'm just going to give you in very simple, what is wavefront guided treatment? Wavefront guided treatment is, there's a machine called aberrometer, which measures the entire refractive error and the aberrations on the cornea, and it gives a treatment on the corneal surface. In other words, it is treating the aberrations of the eye before and the refractive error, but there are some aberrations which are created by doing the ablation itself. Now that is not being corrected. Now what is wavefront optimized treatment? You understand that when you do myopic correction, you are flattening the central cornea. When you do hyperopic correction, you are treating the mid-peripheral cornea, which gets elevated, steepened. So now, this process of making the cornea oblate or prolate, that itself is inducing spherical aberration. And the idea is to make the cornea aspheric, keep it aspheric. For that, they found that some extra laser pulses which are hit in the sides, so that the cornea doesn't become oblate and then lifts up, so that it's a smoother shape. So wavefront optimized, what it did was, besides correcting the sphere and the cylinder, it gave those extra pulses in the periphery, which would reduce the aberrations which are caused by the excimer for the correction. So, but it does not correct the pre-existent aberrations like the wavefront guided. But what they also knew was, minute to minute, hour to hour, the aberrations are changing. Different light conditions, dark, like pupil size. So, you could never measure in toto a static aberrations. Then came, at that time, topo-guided treatment. Now, topo-guided treatment, topography was making maps on the cornea, wherein it was a lot of mathematically calculations were done, which is called Zernike polynomials. And with these calculations, what initially it was done is some corneas have got irregular by poor laser correction, some irregular flap or cut cornea, scarred cornea and all. So earlier, with the topography maps, some values were taken to regularize an irregular topography. But while we were doing topo-guided treatment in irregular cornea, the results were so good. So then they thought, why not we do a topo-guided treatment in normal eyes too? Now, why did that thought come? The thought came because topographic examination, which is done on an oculizer or a topolizer, a lot of peripheral corneal data and peripheral data are made available, like something like 22,000 points analyzed on the cornea. So when you analyze so much, you are treating on the cornea. So does it not make sense? Why do you want to know the aberrations of the entire eye? You want to treat on the cornea, so you need to know the aberrations on the cornea. And these topolizers or topography examinations, they are giving you information on the smaller aberrations on the cornea. So, and the other advantage, whereas the excimer laser was hitting on the pupil center, the topographic guided treatment was hitting on the visual axis. So that seemed to be even better. And it was also compensating for small eye cyclotorsion, intorsion, extorsion movement. It was also compensating for the pupil getting a little eccentric or small shifts in the pupil center. And it was static. It was not variable like the wavefront guided treatment. It was constant measurement. So in this context came the contour vision, which you might have heard patients saying, we do LASIK, I did contour vision. Now that is because in this there's a Placido-based topographic system. from which these values are taken, like 22,000 points are measured, lot of maps are seen, you compare the K values and the different values, remove those outlying things which are not together, choose the best maps, and the laser will hit laser on those points to regularize the shape of the cornea based on the examination input. So then you have, it corrects the minus power, plus power, astigmatic power, but it also corrects some aberrations in the eye. Now you look at this map. Now the topography map gives some information and the refractive data map gives some information. Together, there is also minuscule aberrations which are there even in normal corneas. Even that is measured and corrected. So what Contour Vision promises is, it won't give you only 6/6. It might improve your vision because there are certain inherent aberrations in the cornea which have a reason for that drop in vision or that little glare or little contrast, and it promises to improve that. So what the topolyzer does is, it takes innumerable maps, you look at the mean deviation, remove all the outliers, and then you put all the values at 0. That is, you're not doing any refractive correction. You're just looking at the aberrations on the cornea. It says that only 6 micron of the tissue is being removed. So Contour Vision is correcting the sphere, the cylinder, the small irregularities. It is treating on the visual axis, and it is also compensating for some extortion or intorsion movements and still hitting on the visual axis. So then they decided that there was up to -9, up to 3 cylinder, and all those components were decided. Now take this example. This patient has a 2.75 minus power. The topographies are perfectly normal. And this is the plan, ablation plan. You don't care about whatever I'm saying. This is the pattern of ablation which should come. Then what they do is, they look at the small irregularities which are corrected, and that is the lower map. And then you compare the refractive map and the smaller aberrations which are also corrected. These two maps should look similar. So you have to see that it is very minimal which is being corrected. Now again, this example, just for the refractive correction you need 58 micron. 3 micron is needed for those small trefoils or irregularities on the cornea. And final map is this. And this map correlates with the refractive map when you put them side by side. So you realize this could be done. It is not going to impact the vision. If supposing there's too much of aberrations which are corrected, that would create some kind of a refractive impact. It might correct more minus power than you needed or more plus power than you needed, then the visual acuity would drop. So then, in our initial days, we are doing contour for nearly 10 years. In our initial days, we studied the results of 112 eyes. Some of them had undergone femtoLASIK, some had microkeratome, some had PRK, some had PRK extra, and we compared. What we found was 56% of the eyes had 6/6 vision, whereas 28% had 6/5 and 11% had 6/4. So the visual acuity had improved. Again, further explaining, 56% had 6/6 and 41 odd percent had more than 6/6, 6/5, 6/4. So that was the improvement in the quality of vision. So you realize that the efficacy of this treatment was very good and the patient satisfaction was brilliant. Then somebody said, why not, instead of treating on the refraction, the subjective refraction axis, why not we correct on the topographic axis and see whether that would improve? After all, you're taking topographic maps to analyze. Why not treat on the axis of the topography? But they found that that was not very effective. Then came a newer technique called 4 series method. Don't understand too much of it. How all the evolution happened, that's all you should know. Like the best map is chosen, the data are entered, but what it does is, in 4 series, it looks at the anterior corneal astigmatism, the posterior corneal astigmatism, some internal astigmatism in the eye, and some small aberrations on the cornea, and does a vector analysis, and based on that, it tells this is the refraction which you should correct, and that is done. And they found that the results were brilliant. So this is how it kept evolving, but you had to learn, like we learned how to do a topographic planning based on the data which you entered, that you are able to get good results. So these were the take-home points. Now, topographic treatment in keratoconus. Now we all know that in keratoconus, We are cross-linking, we know that. We know by doing cross-linking, you're tightening the cornea, you're stabilizing the cornea, but there is some kind of a flattening effect which is happening also, okay? Now, but you also know that there are certain irregularities in a keratoconic eye. Don't you know? It's little too conical and some peripheral areas are a little flatter. So the shape of the cornea is not good. And we know that how aspheric the cornea you make, better the shape. So what in topo-guided treatment concept is, this steep area is a central cone. So if you can flatten that area a little, and the green area is the surrounding area, if you do a hyperopic ablation in the periphery, it lifts up that cornea. So you have a central area which was very protruding and steep, is become flatter. Peripheral area is lifted, so you have a larger, flatter cone, which can better withstand the biomechanical stress of the eye, stabilize, and then you cross-link it. Then it becomes stable, and in this process, there is some refractive correction happening. Now for this, to do a topographic treatment on a weak cornea, which is a keratoconus, is an absolute contraindication for LASIK. But here, you're just reshaping the cornea. But for this, it should be only a mild keratoconus, only 450 micron, and you can only remove about 50-60 micron, and the residual should be 400. But then the next question comes, ma'am, would you do only cross-linking at one time and do making the cornea regular at a different sitting? No. We would regularize the topography by ablating just that 50-60 micron to give it better shape, cross-link it at the same time so that the effect gets tightened, because one, you save time, and the cross-linking will remove the haze. She said, no, when you do surface ablation, some haze can happen. So the cross-linking itself will kill the keratocytes and prevent the haze from occurring. And since the epithelium is removed, there's better penetration of riboflavin, so there's better cross-linking. So everything is happening. The only thing is, in normal laser, you plan a laser ablation of only not less than 5, whereas here you can lessen the zone to 5.5. So I'm not going to go into the planning and all that for you. It's too complex. You choose the best maps, you choose the best values, you look at what is, now this is the central steep cone. If you do a topo-guided treatment, this is how the periphery would be steepened and the center would be flattened. And then what important message it carries is, you are one, reshaping the cornea, giving better vision. You still have some, you can remove 50 to 60 micron, so you could remove some amount of myopic correction. Like this patient had 1.5 cylinder, you are able to remove 1.5 and still remove only 31 micron of the tissue. So you are able to correct some refractive cylinder also and give better shape to the cornea. But see, in this particular case, look how steep the cornea is. And look, by reshaping it, the patient still has -2. But with glasses, he has a better quality of vision, as against if he had one bulging cornea and just cross-linked. It wouldn't help him at all. This is, again, a cornea which has lot of inferior-superior asymmetry. Even this cornea could be restabilized. So I'm not going more into it, as it's already too late. But what we understood is, it's not just in keratoconus, but you could do in post-LASIK ectasia, you could do in centered keratoconus or decentered cone. So in different ways, in pellucid marginal degeneration, there are many ways you could reshape the cornea, cross-link it, strengthen it, and thus topo-guided treatment has a place in normal eyes, it has a place in abnormal eyes, which are mild keratoconus too. I don't know how much you understood. You just could have got some brief idea that there is this newer concept of doing refractive surgery in abnormal eyes too. Thank you.
Thank you, Dr. Chitra, for a very comprehensive overview. So we'll just wait for Raghav to set up. Raghav? We'll take the collagen cross-linking talk first. So I'll just break down LASIK for you, what we've covered so far. When you do LASIK or any PRK, you use excimer laser to reshape the cornea, right? Earliest was simply based on refractive error. You tell me your refractive error, I will correct it. And we never looked at aberrations. But eye has aberrations, which is measured through an aberrometer. And the concept of refractive surgeons was that when you correct aberrations, you give a better than normal vision. So came the concept of wavefront guided, where we said, let us measure all the aberrations of the eye and try to remove it. But we were going too far because aberrations are A, not stable, because they are pupil dependent, and B, they also have a role, like we have learned, for depth perception, and we realized that correcting all of it may not be as useful. So wavefront guided was substituted for wavefront optimized. Wavefront optimized means that your eye has some aberrations and you're reasonably doing well with it. So we will not try to take away all the aberrations, but whatever LASIK is inducing, which will deteriorate your quality of vision, we will mitigate the effect, right? So we will not give you more. That was wavefront optimized. So studies have shown that wavefront optimized is as good as wavefront guided. Please note that the more you like to correct, the more tissue you normally end up using. Okay, so that is another flip side. Now, topo-guided treatment is very useful when the cornea is irregular. Because of two reasons: the corneal surface is more stable and you have to regularize it, and the aberrations is not as stable, it is pupil dependent. Classically, they marketed topo-guided that use it for all, but the practical indication of topo-guided is three cases. First is keratoconus, because the cornea is irregular and you have to regularize the topography. Classically, more central cones and milder cases, because you can't have advanced cases, cornea is too thin to do any ablative procedure. Second is if you have done a previous LASIK treatment and that is decentered. Okay? So if a LASIK treatment is not decentered, patient comes back to you with glares and halos, and the patient needs perfect vision because that is the reason he underwent refractive surgery himself. So for that retreatment, you will again need to use topo-guided treatment for recovering the topography and centralizing the treatment. Okay, because in topo-guided treatment, you ablate differently. The areas which have become flatter should not become flatter still. It is the steeper areas that become flatter, and consequently the flatter areas appear steeper. So you're regularizing, okay? So first indication, keratoconus. Second is decentered ablation. And the third is in cases which have astigmatism, right? Where sometimes topo-guided treatments is preferred, okay? So anybody has any questions?
Before you all go further into discussion, I wanted to thank all of you because I'll be leaving now. And I was truly, we've been coming for many iFocus, and I have been doing my ARC PG programs regularly, but I was truly very impressed with the kind of discipline and the thirst for learning which was seen in all of you. Kudos to you. Really wish you all very, very well in all your future endeavors. And I think we all need to say 3 cheers to Dr. Mahipal, Dr. Ritika, Dr. Santosh, Dr. Rolika, and Dr. Rashmin for the kind of efforts they have put, and of course the entire CFS for the kind of efforts they put. Kudos to them, and really very, very impressed. Thanks so much for everything.
Thank
you. All the best.
Thank you. So now we will move on. We'll have Raghav's talk before the ICRS talk, because this is the first treatment you do for keratoconus, right? So we've changed the sequence for it to make more sense to you. So Raghav is cataract, cornea, and cataract, cornea, and refractive fellow at consultant at Center for Sight, and he was the first fellow. He was the first fellow at Center for Sight. So, and he's now one of our leading cataract and refractive surgeons. So he makes us all very proud.
Thank you, ma'am. Okay, good evening. I'm going to discuss about corneal collagen cross-linking, CXL, C3R. There are multiple names to it, but essentially what we are doing is we are strengthening the cornea. So we are talking about a diseased cornea. We know the anatomy of the cornea, it has 5 to 6 layers, of course, but yes, we are talking about the stroma in this talk. We know the stroma is made of collagen fibers, and they are set up in a particular type of way. But in an ectatic disease like keratoconus or a post-LASIK ectasia, the fibers undergo a change in their geometry. So of course, normal cornea has a number of bonds or cross links, but in a keratoconic eye, the number of bonds decrease. And because of a decrease in bonds, the shape goes from this to this. And so these bonds are lesser and weaker. So we have to stop and make these bonds stronger. So what is cross-linking? It is an increase in intermolecular and intramolecular bonds. We have natural cross-linking because of aging, and secondly, in diabetes. Because of glycation in products, we have a strengthening of the corneal links. Secondly, artificially, there is chemical cross-linking in prosthetic valves. Secondly, physical in UV densitometry. In dentistry, we use cross-linking to strengthen the bonds. And thirdly, photochemical in cross-linking. Photo, light, and chemical. So this is a normal cornea which is gone weak. You can see number of links has decreased, whereas after cross-linking, the number of bonds has increased. Historically, Theo Seller was a German mathematician, physicist, and ophthalmologist who was advised by his dentist to undergo cross-linking of both his teeth to harden the bridges. That is where the idea came from. And cross-linking was also used to harden heart walls with and arterial grafts and joint cartilages. So in the earliest testing on cross-linking, it was seen that there was an increase in corneal diameter, collagen diameter by 12.5%, increased stiffness by over 3 times, that is 300%, but there was still some endothelial damage. There was some damage to the endothelium that has to be avoided. The first human study was published in 2003. So this is the basic of a cross-linking procedure. We remove the epithelium generally, and once we remove the epithelium, we douse the cornea with riboflavin dye. Once the cornea is full of dye, you can see this image. The yellow is the riboflavin dye, and once we have the dye, we give ultraviolet radiation of 365 nanometers. For a particular time, we'll discuss the duration of the time used. And then there is production of oxygen radicals, which increases the cross bridges. You see, this is the collagen fibril, and between these fibrils, we have this bond. So these bonds help us strengthen the cornea. You can see how this soft cornea has gone to become a stiff cornea. So the procedure is such that we remove the epithelium. Epithelium is removed. Then we put drops of riboflavin dye till the cornea is drenched in it. And of course, we see some of the dye particles inside the anterior chamber. And then ultraviolet radiation is focused on that area and the bonds are formed. What are the effects of this on the cornea? So initially, there is loss of subepithelial and anterior stromal nerves, which is very important. Secondly, there is loss in number and rarefaction of keratocytes. But ultimately, at 3 months, we see that the keratocytes start forming, and they form with such a massive number that there is some haze. So this haze in cross-linking is a double-edged sword. It's helping us in bonding, but however, it can be deterrent to vision. So we have to manage this haze very well. At the end of 3 to 6 months, we can see that there is a demarcation line that is formed in the corneal stroma, which is at about 350 to 400 microns, which we can see by anterior segment OCT. The stroma, of course, it affects only the anterior 250 to 300 microns. That is why it is very essential to have a decent thickness for our cornea before we begin with. We cannot do cross-linking in a very thin cornea, though now we do have systems where we can do cross-linking in thin corneas also. Increased intra and interfibrillary bonds, increased collagen diameter by 12%, and increased strength by 3 times. There is increased rigidity by, like I said, 3 times. So this diagram I'm going to show you is showing us the thresholds at which we can have toxicity of the dye and ultraviolet radiation. What is most important is that our endothelium is somewhere at 0.35 joules per centimeter square. So if the radiation reaches the endothelium and it crosses the toxicity level, we will have irreversible damage. So it is very important to protect our endothelium. Why? Because in a patient of keratoconus, of course, the stroma is already diseased. We do not want to hamper the endothelium. What are the indications of cross-linking? Keratoconus, yes. Pellucid marginal degeneration, post-actic ectasias, corneal melts, and infectious keratitis. Yes, even in keratitis, we do see that cross-linking helps in strengthening the bonds, and also it removes the bacteria more than fungal. So contraindications to cross-linking, the thickness should, after removal of the epithelium, should be between more than 400, but now we do have systems where even in thin corneas we can have cross-linking. Pregnancy and lactation is another relative contraindication. Severe corneal opacities, post-herpetic infection as it can lead to reactivation, poor vein healing, and autoimmune diseases. Who are the ideal candidates for a cross-linking? Mild to moderate keratoconus cases, we don't go for very severe cases. Pachymetry of more than 400 micron is ideal. Little or no scarring to begin with. BCVA better than 6 by 12 or 6 by 9 at least, and earlier in the disease. If we go in for the crossing in a later stage, it can cause more scarring and therefore more damage. Patient has to be counseled that this is only a preventive procedure. We are not going to treat keratoconus. We are only going to stop the progression. Yes, we do see that more than 85% cases have progression, have a stoppage of progression. Depends on what age you do it. Later the age, more the chances of stoppage of progression. Earlier treatment is better for the patient, preventing more than fixing the problems. Patients usually still require contact lenses, the specialized contact lenses for better visual acuity. So what the original protocol described was a Dresden protocol, wherein epithelium was removed in the central 7 mm zone. Isoosmolar riboflavin was used. There are different types of riboflavins used. We will discuss in a bit. With 20% dextran, 1 drop was given every 3 minutes for 30 minutes. So till 30 minutes, 1 drop was put till the entire cornea was drenched or it was saturated with the dye. And then we check for saturation of the cornea and we see presence of dye in the anterior chamber. We check the calibration, and then intraoperative pachymetry has to be either more than or equal to 400 micron. Ultraviolet exposure was given at a distance of 6 centimeters from the cornea at 3 milliwatt per centimeter square for 30 minutes. That is 30 minutes, so it almost took us 1 hour per eye. So the original protocol took almost 2 hours for 2 eyes, which was a very cumbersome procedure. And riboflavin dyes were given every 5 minutes during the radiation, and at the end the BCL was removed. The epithelium could be removed either by using a simple hockey stick or a Tooks forceps, or manual alcohol removal, or we can do a PTK. But most commonly we use the hockey stick or we use alcohol. So now we can do cross-linking by 2 methods. One is through the epithelium and one is after removal of epithelium. Trans-epithelium cross-linking is used if the cornea is thinner than 400 micron. There is significant reduction of pain and danger of post-op infections, but the dye we use is different than normal. It has a 0.25% riboflavin with 1.2% HPMC and some protection, that is the benzalkonium chloride. The standard riboflavin solution with dextran with epi off, that is after removal of epithelium, it is the one described in Dresden protocol. 0.1% riboflavin with 20% of dextran 500. It is a thick solution. The osmolarity, of course, is 402 milliosmol per liter. We also have that is a hypoosmolar riboflavin that is used for thinner corneas. When we use the hypoosmolar riboflavin, it tends to increase the thickness of our corneas. So this is our hypotonic riboflavin dye. The osmolarity is much lesser, 310 compared to 402. So this swells the cornea. Now we also have cross-linking for our LASIK and PRK and SMILE procedures. Once we do a refractive procedure, that is a PRK or a LASIK or a SMILE, especially in corneas that are thinner or who do have some topographic changes that are not very healthy looking. For such cases, we can combine a cross-linking immediately after a refractive procedure. I will show you a video later. Now the post-operative treatment, patients are given a banded contact lens which is removed at about 4 days till the epithelium heals, antibiotic drops, painkillers if required, topical NSAIDs, steroids to, of course, to decrease inflammation, and we remove the contact lens at the 3rd day. There are variations of cross-linking. One is the most important, that is accelerated cross-linking. So now the original protocol described was almost 1 hour per eye. 30 minutes we used to put the dye, and then 30 minutes irradiation. That is 1 hour per eye. But now what we have is an accelerated cross-linking that is based on the Bunsen-Roscoe principle of reciprocity. That is, if we do have 3 milliwatt per centimeter square for 30 minutes, this is the same as 30 milliwatt for 3 minutes. So we can increase the irradiation and decrease the time. The effect is almost the same. However, studies did find that going above 45, somewhere over here, does not increase the effect of cross-linking. So what we usually use is 9 milliwatt for 10 minutes. That is, so only a 10-minute irradiation is given. We put the drops, and then for 10 minutes we give irradiation. So one eye can be done in about 25 to 35 minutes. So it is seen by multiple studies that the standard cross-linking has a greater effect in terms of reduction in the keratometry. However, the accelerated cross-linking induces lesser reduction in CCT, that is the thickness. So in thin corneas, there are multiple ways by which we can do a cross-linking. One, like I discussed, we have hyposmolar riboflavin, that is we use riboflavin with a lesser osmolarity. We can do a trans-epithelial cross-linking, that is, we use different type of dye, but we put the dye through the epithelium. So trans-epithelium, epi-on and epi-off has been discussed multiple times. There are a few differences between the epi-on and epi-off. Most important is that, of course, we can use the epi-on only with corneas that are less than 400, and epi-off can be used, and it is not recommended for thinner corneas, the epi-off. Incidence of progression has been seen to be a little higher in the epithelium on procedure. This is also discussed, that is iontophoresis assisted cross-linking, that is electrodes are placed at the forehead and the canthi. This increases the absorption of riboflavin, and then the UV radiation is introduced. Our group has also discussed the tailored stromal expansion, that is a SMILE lenticule assisted cross-linking. Immediately after we do a SMILE, the SMILE lenticule, being just made of entirely stroma, is placed on top of the patient after epithelial removal. The thickness of the stroma is hence increased, and then cross-linking is induced. I'll show you a quick video. So this is epithelium debridement. Once epithelium is debrided, on the donor patient, SMILE is being done concurrently. As the SMILE is done, the lenticule removed from that patient is put on the patient who is to undergo cross-linking. So once this is done, so technically the thickness of our cornea is increased. Once we check the thickness, then dye is introduced and cross-linking is done. But very important, after procedure, we have to remove the donor lenticule and a lens is placed. Some groups have also discussed contact lens assisted cross-linking, that is, we put a contact lens which is about 90 microns on top of the epithelium debrided stroma and then put dye and then do cross-linking. But now we also have something known as adapted fluence, that is for patients who have lesser, very thinner corneas, even for 250, 300 microns, we can adjust the irradiation and the time for which it is given. So no patient can be denied a cross-linking. So of course, a LASIK PRK or a SMILE extra immediately after the procedure, we do a cross-linking. So this is done for patients who are just the borderline cases for refractive surgery, who have a higher refractive power, who have hyperopic LASIKs, who are younger patients, who have borderline topography corneas that are thinner. So this is a case of SMILE extra. Immediately as we do the SMILE, once SMILE is completed, we introduced dye inside the pocket and then irradiation is given. The irradiation given is half that of normal. The complication I'll go through quickly. One is of course post-operative infection, which is very common as after every procedure. So we have to manage the complications well. Secondly, corneal haze. Dr. Rupal ma'am discussed in depth how we can have corneal haze. Of course, it's like I said, it's a double-edged sword. We have to prevent it, but of course, it is also healthy for the haze to occur. Endothelial damage can occur if we do very deep cross-linking. We have to protect the endothelium. We have to have adequate amount of thickness. Peripheral infiltrates are very common, have to be managed with steroids, and herpes can be reactivated. So we have to give preoperative antiviral drugs. And treatment can have failures, especially in patients who are 35 years or older. So we have to see and do a pentacam or a topography serially after the cross-linking to see that the patient is doing well or not. Thank you.
So for all of you, let's break down cross-linking. Why do you remove the epithelium? The first step is epithelial removal, right? Why is the epithelium removed? Of only riboflavin or something else also? You are missing the third element of cross-linking. Oxygen. Okay? So cross-linking requires three things: riboflavin, oxygen, and the UV light. Okay? So transepithelial cross-linking there are two problems. One is the riboflavin doesn't move in. Second is oxygen also doesn't diffuse as much. So it is the oxygen which is the free radical of oxygen which causes the cross-linking. So that is why epithelial removal is generally recommended over transepithelial. Okay? What is the concept of accelerated cross-linking is that we decrease the time by increasing the power. Total energy remains the same. But after a certain level beyond 9, this is not effective. Why? Because enough oxygen doesn't come in. So oxygen then becomes the rate limiting step. Okay, so you must keep the invisible element of oxygen in mind. One very important question is, when do you cross-link? Do you cross-link any keratoconus? When do you cross-link? How do you define progression? What on pentacam? What happens to the corneal thickness and keratometry?
How much does it change?
Okay, refractive power, right? So you can ask for history of BCVA or spectacle, and if it is changing more than 0.5 diopter, keratometry, what will happen to it?
How much will it change? Over?
Okay.
1 year.
6 months to 1 year actually. But
Point-
if it has changed by 6 months, obviously that's fine. You keep following up. There is two other criterias. Corneal thickness. 10% change, that is correct. Last. Hanji? It's the change in the curve of the contact lens of the RJP. Okay, so these are the 4 criteria: keratometry, thickness, refractive power, and contact lens. You must know that cross-linking is done at when the keratoconus is progressive. There are a lot of ways of doing cross-linking in thin corneas, but they are now no longer relevant because the concept of adaptive fluence is there. In accelerated, we keep the total energy the same, vary the power and the time. But in thin corneas, we reduce the energy. The thinner the cornea, the greater is the reduction in energy. And that is what you use. Okay? Any questions for Dr. Raghav? We now move on to talk from the previous session, which is from Dr. Mahipal, on SMILE, the future of refractive surgery.
Thank you very much. Good evening, everyone. I'll be talking about the procedure of SMILE. So when we are looking at LASIK, which you have heard in the previous session, we started the refractive surgery with conventional LASIK, which essentially involved the use of a blade microkeratome and to make a flap. And after making a flap, the excimer laser was used to reshape the cornea. So that is the basic. And LASIK, all of you know, stands for laser in situ keratomiliosis. That means that you are shaping the cornea from within. So then came in about 2005 the blade-free LASIK, wherein what I told you in the femto cataract, there is the use of the femto laser to create the flap, and that reduced the complications significantly. Actually, the complication was pretty less with the microkeratome itself, but the safety factor increased significantly, and it became more, one can say that it was more forgiving. Even if there is a femto, there is a problem, like in a flap, if you are cutting a flap, if there is a problem, you really can't do anything. You have to abort the procedure if you have free flap and things like that. So those buttonholing, free flap, those kind of things were significantly reduced when you went on to the blade-free LASIK. And from the blade-free LASIK, obviously the concept now, as you know, that anything which is a small incision heals better, heals faster. And Relax Smile Kalim, and Relax Smile stands for? Go ahead. Relax is refractive lenticule extraction. That means that you are extracting a lenticule of the cornea for refractive correction. And SMILE stands for small incision lenticule extraction. So SMILE is basically a form of Relax, which is refractive lenticule extraction. So that is what it is, that you are using the femtosecond laser to carve out a lenticule of a particular, for a particular, and the amount of tissue that you take for ablation in excimer / what you are taking is the same, because it's the Mullerian formula that is applied to have the change in the curvature. So this is actually, when you are doing a procedure for lenticule extraction, there are 4 steps that happen. The first step is, you can see this red one, which is the bottom of the lenticule. Now, one important thing when you're looking in SMILE is that irrespective of the power that you are treating, the time taken will be the same. Okay, when you are working with an excimer laser, you have to burn X amount of tissue, say 13 microns, 14 microns per diopter. So burning takes a particular time. So if you have 10 microns to burn, the time taken will be 10 times more than what you are doing with this thing. But here only the depth is going to change. That means if I am doing 1 diopter, this much is the depth. If I am doing 10 diopters, this much, but then it is going to be only cutting at a different level. So the first phase is this red line, which is here also, which is here, is the bottom part of the lenticule. Okay. So you pass it at the bottom, then what happens is that you get, as I told you, you have those dots, these spots coming, and then they expand. So that is called as OBL. Somebody can ask you, what is OBL? OBL stands for? Good. So you form bubbles. So opaque bubble layer, तो आप ऊपर से काट के नीचे नहीं आ सकते. Similarly, like I told for the nucleus, नीचे से ऊपर जा रहे हैं. Similarly, here also the first is posterior. You form the opaque bubble layer, and then the femto cannot penetrate through that opaque bubble layer. So then you have to come to the upper level. Understood? So the second is this round one. That means that you have made the posterior, then you are cutting, and then you go on to the cap. This is called as the cap, which is larger. So you have the optic zone, which is here, and then this is the transition zone. So you have a cap that is made. So there is no flap, but there is a cap that is made. So this is the third, which is larger, and then you have the side cut, okay, or the entry cut. So this is called as the entry cut, from where you are going to take out the lenticule, and this normally has shrunk to about 2 millimeters. Normally most of us keep it at 2 millimeters or 3 millimeters. So that is the incision that you have. Now the basic principle where it differs is that in a femtosecond laser, all you need is a transparent cornea. So if you have a transparency in the cornea, you are able to focus at any layer that you want. And this being a photo disruptive laser, this also question can come to you, and an excimer laser, as has been told, is a photo ablative laser. So for burning anything, it will burn on the surface. You cannot do an intrastromal burn. Understood? So therefore, you have to create a flap, you have to get a raw surface, and then you have to burn that particular surface. So you have a photo ablative, which is the excimer laser, which has to be on the surface, but a photo disruptive, you can focus at any depth, and you can get this disruption. The corneal reshaping that you have, the factors which are there outside in the room. So basically, if you have organic vapors, like it is said, when you're doing an excimer, don't put perfumes and things like that, because these are organic and they can decay the laser that is firing. If the temperature, humidity is not under control, if it is more humid, the extent of excimer that is coming onto the cornea, because this is where the laser ends and this is where the cornea is. So there's a gap between the two, so the atmosphere environment makes a difference. So if you are in a hot, dry place, the burn would be more. If you are in a cold and more humid place, the burn would be less. Understood? But in femto laser, it is purely a focusing mechanism. So it entirely depends on the numerical aperture, and the standard deviation of a focusing mechanism is much less as compared to a burning mechanism. Okay? So you have to just be good and focus, and that is what it is. The corneal hydration therefore makes a difference. If you have left too much fluid on the cornea, so the burn would be less. It's pretty, or agar yahan aapka AC is directly on and you have dried up the cornea before the excimer is firing, then the burn can be more. Okay? So therefore these are the things that you have to keep in mind. This is the SMILE procedure. You can see this is the posterior lenticule cut. Okay? So this is coming from out in. And then you, because you want less time for the OBL to expand, you have the side cut, and then you go from in to out. Okay? So this is the next, and then you see that this is the side cut which has been made. I'll just go forward. So then what you have to do is that you go The surgery, what it involves is that you have to go into the proper plane. So you go on the top of the lenticule, and then you go at the bottom of the lenticule. There are various signs that have been described by us. There is the stop sign, like if you are going this, you are getting a stop, so that means you are in two different planes. There is the shining ring sign, and then there could be the meniscus sign, but you can see that this is a dissection. So wherever the plane has been created, all you have to do is to dissect out, and this is the blunt spatula, and you are just able to kind of connect the spots that have been done. And then you go to the upper side, as you can see here, and then you don't take out the whole thing from one side because it can roll over. So you are going from one side, leaving an attachment, and then you can see that this is the posterior of the lenticule that we are doing, and you can see there is the disengagement that you have, and then it's really the least invasive. You can see we just take a forceps and we just pull out the lenticule. Okay, you can spread out the lenticule for beginners and see that the lenticule is completed. There is as you compare to excimer, as you see that the cornea is having a particular shape, so therefore the burn which is happening at this end versus what is happening in the center in an excimer laser could be different. And SMILE has an exact aspheric lenticule. If you have an aspheric lenticule, it is more forgiving even if there is some decentration. So that is the other advantage that is there. Now let us just see the nerve. You all know that the nerves come from the periphery of the cornea. So if you are cutting 2 millimeters from there, so that is only where the nerves will be cut, and the rest of the nerves will still go into the cap. Okay, and if you are doing a flap which is a 22 millimeter flap, you can see here, then under those circumstances all these nerves are going to be transacted, and therefore it has been established that exactly when you are so it is 80% less side cut, 40% less cap cut. So therefore confocal microscopy that has been shown, and I will show you some more confocal microscopy. The nerve regeneration and the dry eye has definitely been shown to be much less in cases where you are doing a lenticle extraction. This is the corneal sensitivity by Cauchet Burnett, and this again you can see that in LASIK as compared to SMILE, it is much better when you are looking at a SMILE. The other thing which is yet to be proven, but there are studies which are hinting towards it, that there are several studies which have been done that the anterior stroma contributes more to the biomechanical strength of the cornea as compared to the posterior stroma. So what you are interrupting in case of a LASIK is that the flap is being created plus the ablation, and that is right from the top. However, in SMILE you are just taking out the lenticule from the mid-stroma. So there are indications and there are studies which are showing that the biomechanical strength of the cornea is better preserved in SMILE as compared to LASIK. This is just to show you the biomechanical superiority, because the lenticule, the same thing that I have shown you before. The other thing is there is no flap, so there is no displacement, there is no buttonholing, microstria, etc. There is less epithelial ingrowth, rarely is seen, but you can have it. DLK, etc. is also less. So this is the contact interface that you have, which is a 360-degree contact interface onto the limbus, minimal applanation, no distortion, and minimal IOP rise that is there. So this is how the patient fixates, and the patient is to see it almost throughout till the OBL comes to the center. So till that time the fixation is pretty well maintained and you get good outcomes. Now the only problem with SMILE just now, one of the problems is that you cannot retreat a SMILE with SMILE because there is already a potential place. So what you do is called as a circle scan. That means that you enhance, you make the cap into a flap. Do you understand? And I'll just show you. So this is the cap that had been created at the same parameters that you have. Say if you went at 110 microns, you can see this is expanding. So we are making this cap, it has gone extended, and then you have made this inner cut that is coming and the outer cuts. So technically you are able to lift it. You can see this very clearly. You can see this is where the lenticule was taken out, and now you have a fresh cap, fresh flap. And doing a relift of a flap causes more epithelial ingrowth. Kabhi bhi aap LASIK, if you have to do an enhancement, if you relift the flap, the apposition is not as good. So you tend to have epithelial ingrowths which you do not have when you are doing a fresh cut. So that is the advantage that is there. So this is what it is, that SMILE then LASIK is actually much safer than LASIK again after LASIK. Do you understand? So that is simple. This, I'll just skip this. This is suction loss. You can manage it as it is. So I'm just going to now tell you, maybe this can come. There are, at present, every company is moving towards this lenticule extraction. So these are what are available. Just now, what we had earlier was the Zeiss platform, which is called as the Visumax 500. It has gone on to Visumax 800. And then you have the Zimmer, which is LDV. Schwind has come out, and now Elita, which is J&J, they have come out. So you can see here that the wavelength is pretty much the same, but the pulse repetition rate is going up and the power is coming down. Do you understand? So the pulse, the spots have become smaller and the repetition rate has increased. So if you see that the amount of pulse energy that is there from a 150, which has gone down to 50, okay, nanojoules, that is there, and the time that is taken for the laser cut is now down to 10 seconds from earlier 26 seconds, and now this is 16 seconds in J&J. I'll just show you, this is the new machine. We have had the opportunity to work with this for both FDA phase 1, phase 2, phase 3, and now it's going to be limited market release. This is the J&J machine. Just to show you, this is how the procedure is done. This is a suction ring. This is a 2-piece PI. The one that I showed you earlier is a single-piece patient interface, but this is a 2-piece PI. So you can see here that this is the suction that we are going to have. The patient interface is coming down. Can you see this? This is the interface that is coming down. You can see we are docking, and here you can see the docking through the microscope view. So you have a flat applanation which will be there. You can see this. This is the applanation. This is the applanation. You just pinch it so that it comes down and you can applanate it further. And this is so this is ready. Now what we can do here, which was not available earlier, is that you see I can change the centration. Can you see this? And you are seeing I am doing a cyclotorsion compensation. So this is the advantage. You have to mark on the cornea. So this has both the centration as also the cyclotorsion, which was a disadvantage with the earlier machines. But new machines, even Zimmer, I think Bharti is here, that also has, you can mark and do a cyclotorsion compensation, which is important for, cyclotorsion compensation is important for the cylindrical errors, okay, because the axis, if it changes, that's a problem. So you can see this is how the laser is firing, and it is the same steps, and you can see here that this is the end with the OBL, this is the microscopic integrated OCT which is there. You can see this area, this is where the lenticule has been created. Again, we are entering, as I told you, so this is one plane and this is the other plane, and you can see when one comes back, it kind of, there is, I didn't show you, but there's a stop sign which is there. Again, you can go and you can see on the microscopic integrated OCT, can you see we are above? And you will see later that as we go in, after separating, these are the dots you can see for the alignment central as also for this thing, and for the cyclotorsion you can see again we are below the lenticule now, and once we have this edge also separated, you can see the lenticule is almost out here. We'll just pull it out. You can see the lenticule is being pulled out, and you can put it here. You can see that's the lenticule. You can spread it, measure the signs, etc. So this is the results. This procedure, they call it as silk. Okay, so this is lenticular keratomileusis. Okay, so this is smooth as silk. That's what it is, because the amount of dissection is much less. And what we have seen is that 88% of the eyes achieve 20/20 or better UCVA within 1 week post-op. So the amount of energy that is delivered on the cornea and how easily you are able to separate, which I have fellows sitting here who have done smiles, and I think the learning curve is pretty low. Now what we said was 50 eyes, I think the learning curve is down to maybe 10 eyes that is there. And you can see that the vision tends to keep on improving in the cases of lenticule extraction, and you can see 96% of the patients had 20/20 or better over time, which is there. 0% of the eyes lost any lines which is there. There was 8% had 2 lines or better, and 94% of the eyes were within half a diopter of 0, and that is fantastic results with the machine that you are getting. And you can see that this is excellent refractive predictability. Cylinder correction is also excellent, and we have corrected cylinders up to 5 diopters which are there. So friends, these are early results that we have with the limited market release. I think there are going to be about 14, 15 machines in the world. So we were the first center to do these trials, and then NN did it, and now there is Hong Kong and there is Croatia and those things. But suffice to say that like phacoemulsification went ahead and replaced larger incision ECCE, in this particular case, in this arena also, the retreatment rates are much lower in SMILE as compared to others. The evolution of refractive surgery is heading closer to preservation of corneal biomechanics, less injury, less invasive, and refractive lenticule extraction is the latest techniques towards this. And another important point that refractive surgeons are aiming to achieve is an abrasion-free treatment. So tomorrow there is a thought that you can also give wavefront lenticules that you can do, and lenticule procedures are one step closer to this quest. So this is all that I wanted to tell you, that this is the procedure. Dr. Bharti is here. I think he also does most of his cases as SMILE. We all prefer to those who are having the lenticule extraction. They are actually very happy with the lenticule extraction, and the outcomes are really fantastic. Thank you very much for your kind attention.
Thank you, sir, for the wonderful presentation that you've made. I think sir is a living legend for SMILE in the current scenario. Anybody has any questions from sir? Yeah. Yes.
How you are comparing, you're trying to do an apple and an orange combination. The point is that Contura Vision, what is Contura Vision? That's just actually a lot of hype that has been created. That's just a customized topo-guided ablation. So you can't combine an excimer with this thing. Whenever you have to do excimer, you have to make a flap. Contura Vision is basically a LASIK. And it is, you can say, old wine in new bottles, because customized LASIK, 2000, that is when we started Xioptics. Xioptics is the thing that came with Bausch & Lomb. And at that time, the results were horrendous in the sense that we would say garbage in, garbage out. In the sense what you are measuring on the wavefront, you can't really do 2 microns, 3 microns, 1 micron. And when you are correcting a wavefront abrasion, it can lead to, there used to be an overcorrection because it led to burning more corneal tissue. So there is, and not a majority of the corneas, more than 90-95, don't need a topo-guided ablation. Maybe 97, 98. So contour guided doesn't make any sense, because an aspheric ablation gives you as good, if not better results than if you are doing a contour guided. So because you are burning away tissue which may not be required to be burnt away. So there is no question of combining SMILE with Contura Vision. What they are saying is that with the eye design, you can actually look at the wavefront abrasion and then try to actually make small changes in the lenticule. But I don't think the benefits are there to that significant extent than doing just an aspheric ablation in all these cases. Any other question? Okay.
Thank you, sir. Next, I would like to invite Dr. Ritika Sachdevo, who will be discussing about intracorneal ring segments.
So I'll just be talking about intracorneal ring segments, which is basically used in ectatic corneal disorders like keratoconus. When you are doing LASIK, you are ablating the cornea. When you ablate the cornea, you remove tissue, so effectively the cornea becomes weaker. So when the cornea is already weak in patients like keratoconus, you have to do tissue additive technology. You can't remove tissue, so you add artificial tissue such as the ICRS, which is basically PMMA segments. Okay, so the indication of ICRS is usually in conjunction with C3R. C3R is to stop the progression, and ICRS is to correct the shape. If the keratoconus is mild and the cone is central, you can use topo-guided PRK. But in more advanced cases, especially with an eccentric cone, you want to regularize the shape using ring segments, which can push-pull the cone centrally and flatten the cornea. Okay? So these are segments like this. These are tiny arcs of PMMA, which are implanted in the stroma. So they come with various trade names. Most commonly used was the intact segment. Then you have the Ferrera rings. You even have Biotech having launched Bio rings, which is the Indian version. These differ in their specification. specification varies depending on the cross section and the thickness and where they're implanted. These are technical things which you need to know only when you're implanting. But just remember, these are different rings with the same purpose. Now, how do they work? If all of you have seen a hammock, if you put a spacer in between a hammock, right, it becomes flatter. It doesn't bend as much. So if you have put a spacer device, this is basically a spacer device, it's going to make the central arc flatter, right? That basically means the cornea becomes flatter, and in keratoconus, that means your shape is getting better. Also, what is very important is that the tension gets redistributed. This redistribution of the tension plays a very important role because keratoconus progresses due to the biomechanical stress. So if you have reduced the overall tension in the stroma, you perhaps are reducing the progression of keratoconus also. So this is an added role of ICRS, but classic treatment to reduce progression remains cross-linking. Okay? Now, this is what it does. You have placed a spacer segment, so the cornea becomes flatter centrally, and it also pushes the cone more centrally if the cone is eccentric. When will you use ICRS? See, if a patient has keratoconus, he's seeing well with contact lenses, you don't need to give him visual rehabilitation in the form of ICRS. So classically use it for people who need visual rehabilitation and don't want to wear a contact lens. You are going to spare them a corneal transplant. Central cornea has to be clear, because even if you correct the keratometry, he has to look through the visual axis. So central cornea has to be clear. And when you implant this segment, you need enough stroma so that the overlying cornea is stable enough to have a secure segment inside it. So you need a thickness of 450 microns. Now you all may be wondering, you may not get 450 microns in keratoconus, but note this is not the central thickness. This is implanted in the 6 to 7 mm or 6 to 8 mm zone. So there you will usually get a 450 micron thickness. Okay? How do you assess a patient for ICRS? You do a complete refraction. You see the axis of the positive cylinder. Okay, when you refract, you remember you can transpose. So you always refract so that the cylinder is in the positive cylinder form, and you take that axis. You also do a topography. And okay, now let's come to this. So how do you choose a segment? So the thicker the segment you will choose, the more will be the correction. That's obvious, because it's a thicker segment, it will flatten more. So if the spherical equivalent you want to change is more, that means the cone has greater keratometry or greater refractive error in terms of sphere and cylinder, which is the spherical equivalent, you will use a thicker segment. Also, if the segment is implanted closer to the pupil, the effect on the central area will be more. So implanting it closer to the pupil, for example, the intacs SK segment is closer to the pupil versus the intacs, okay? So closer to the pupil will get more effect. The side effect is visual disturbances. But then they change the cross section in a manner that the visual disturbances are less, okay? So thickness and distance from the pupil will cause greater correction. How will you select the segment? Now, if the cone is central, you just want to flatten it, right? So you will push them down equally from both sides. So you are going to use symmetric segments. If the cone is eccentric, you want to get it central. So you will use a thicker segment in one portion and a thinner supporting segment or one segment. Okay? So this is how we do the surgery. Earlier, ICRS went into a lot of disrepute because mechanical dissection was done, which had more complications. Now with the femtosecond laser, it has very less complications and therefore has become popular again. This is how you use the femtosecond laser to create the channels, okay? And then you simply, whenever a femtosecond laser is done, it is not like a blade dissection. There are some tissue bridges. So you simply create the plane, go in the same plane, and then you will wheel in the ICRS segment. The ICRS segment is made up of PMMA. You will guide it in, and if you can see, there is a small hole at the distal and proximal end. So after you guide it in, you push it in. In the last bit, you will put a Sinski to engage it in the hole to push it about 1 millimeter inside the incision. Why you push it inside the incision is so that it doesn't extrude out, okay? and then you put the other segment from that side, right? So this is a very simple implantation procedure. I'll just show you a few case reports. This is a patient with keratoconus. This is the pre-op refraction, minus 1.5, minus 3.75. Like I said, cylinder has to be in positive form, transpose, okay? Now transpose, which is more, the sphere or the cylinder? The sphere is more. Is this cone? There are two ways of defining a symmetric segment. You will need a symmetric segment if the cone is central. That means the steepest point on the posterior float should be within the 3 to 5 mm zone. Okay? Or when you do the refraction, the spherical component will be more than the cylindrical component. Okay? So this is what this patient has undergone, 2 symmetric segments. And you will see this is what the patient looks like post-operatively, and the corneal topography will have a steepening which has been reduced, keratometry reduced, and a better BCVA and UCVA. Both will improve. Okay. Similarly, this is a patient who has a more eccentric cone, so therefore the cylinder is more, right? Even in the transposed form. Another question which may be a little advanced for you, but if you have to implant the ICRS, you normally make an incision at the steep axis like you do in phaco, right? And it is very important that you have the axis right. So how do you determine the steep axis? Is not by topography, it is ideally by refraction. Whatever is your steep axis by refraction, you will consider for ICRS, because you're trying to correct refraction here, okay? If suppose your refraction is not accurate, because sometimes you have a lot of scissoring and you can't get the accurate refraction, then you will rely on your topography. Mostly, both the axes should be roughly similar. If there is a variation, you go by how good your refraction is, how reliable, pick refraction over topography. Too much scissoring, can't figure out axis, refraction is not giving much BCVA improvement. So then you go on topography. So this is an eccentric cone, so you are going in for a thicker segment inferiorly and a thinner one superiorly, or you can go in for a single segment. 2 small points that you should know. ICRS is usually combined with CXL. If you have a choice, you can either do it simultaneously or you will do it sequentially. If you are doing it sequentially, which will you do first? Which will you do first? ICRS will be done first, because the cornea is supple enough to be reshaped. Once you reshape the cornea, then you stiffen it. If you do ICRS after cross-linking, the effect becomes lesser. Okay? So this is a very interesting case of a lady who developed post-LASIK ectasia after her pregnancy. So this is how she came to us. So we did the C3R, because this is her progression. See, this is early ectasia. This is how she's progressing. So if she's progressing, we will do cross-linking, okay, because her BCVA was good. We did not do intacs in this eye, but in her second pregnancy, she progressed even more. This is her other eye, which was more advanced. So we had done CXL plus ICRS, and this eye did not progress during her pregnancy. So what does this show? That in post-LASIK ectasia, sometimes the effect of CXL is less, and it also shows that ICRS has a role in stopping the progression. So if there is one indication you have to give for ICRS, it is post-LASIK ectasia. Because in keratoconus, even CXL and PRK and topo-guided PRK have become more popular, and ICRS has become less popular. But in post-LASIK ectasia, it remains a very, very common modality. Just to show you some videos of once the ICRS is in place, do note that you need to advise the patient not to rub the eye. There are risks of infection, melt and extrusion. So if the surface of the stroma over the ICRS melts, the reepithelialization will not happen over the PMMA, and you simply explant the segment out. Okay? It's very easy to explant, and the cornea is a very forgiving tissue. It heals very well. Okay? So so ICRS can be explanted. Sometimes when the ICRS is in place, especially because VKC is very common in patients who have keratoconus, you may see a white cell reaction around it. this must be treated with steroids. There are other deposits like calcium and lipid that may be there which don't require treatment, but they will not come in with an inflamed eye. Okay? So these are the risks of the ICRS implant. And this is how you will have to, this is how the cornea looks even after the ICRS is removed. Thank you for your attention.
Thank you, ma'am, for the wonderful talk. Ma'am, one question from my side. Do you keep the patients on lubricants for lifelong on these patients of intacs, considering the irregularities that are created?
So it is advisable to give the patients lubricants because the corneal surface will never wet as well. It is also very advisable to tell the patient to never rub their eyes because that will increase the chance of corneal melt. So the patient, and also report quickly to you if they have significant persistent redness because that also is something that they should be
Melting. Okay.
mentally prepared. Also, if you're doing ICRS, you should tell the patient preoperatively that there will be an implant that will be visible because some of them do not want that other people know about their keratoconus. So this is a part of the preoperative counseling. Okay.
So anybody wants to ask any questions? Yes, we have one question.
So in refractive surgeries, you basically have iris in refractive, so you're not talking about ICRS. In refractive surgeries, you normally have a pupil scanner, okay, which by assessing the pupil, it has, is able to compensate for cyclotorsion, okay. So this is what the cyclotorsion compensation comes in because of the pupil recognition, okay.
Anybody else wants to
Iris
ask any
recognition
questions?
actually. Pupil, yeah, iris recognition, iris pattern. Yeah, iris recognition. The iris pattern. Okay, and pupil tracking to make sure that when you are ablating, that it is ablating in the center to compensate for eye movements and the centroid shift. So the iris recognition for cyclotorsion and the pupil tracking. These are the advances that have helped the ablation become centralized and more accurate.
Thank
Okay, so it's like your fingerprint. So you have the iris recognition and then there is something called as iris registration. So first thing is that is called IR. So iris recognition happens that ye same vyakti ki you are doing the right eye and the left eye that is there. It is very, I have in my entire life one eye that has been recognized wrongly. But otherwise it's as specific as your fingerprint. So you have both a recognition and a registration. So you are recognizing and then whatever आपके iris scripts वगैरह जो होंगे ना, that is kind of taken a picture and then if there is any torsion, it adjusts according to that कि भाई आपका whatever is the cyclotorsion you adjust and the center of the pupil which you get on the eye design which you have on the wavefront measurement in the OPD, that is aligned to the center when you are on the laser. So the center locks on the center. So once it is locked, until of course there is a huge movement in the eye, then it stops. The laser stops to fire. But if it is within the range, then you have a tracker and you have the shift in the laser that is there. It tracks the movements and then it shifts and it still fires on center. Okay, so that is very important. That's what was lacking, what I told you in the smile procedure. But in any case, since it is suction and there is dock, it is already a dock, so you don't have any movements in the eye. You can lose a suction, that's something different, but you don't have any movement. So all the excimer lasers today have inbuilt iris registration, tracker, torsion, centration, all of those things are tracked, so you don't have. But if you by chance track it wrong, or track means if you lock it wrong, then the whole ablation is going to be decentered, which is obviously not the case now, but that is what it is. Bharti, you want to say something?
The only thing which I want to add is that the movement is within 1 millimeter. If it is more than a millimeter or the torsion is more than 2 degrees, the examiner stops firing. So those two things are very important.
you. I think even Smile machine is coming up with the advancement Visumax 800 for the torsion, for the cyclotorsion control. So
It is 800 has come out. The centration again is manual, and this is also manual. So all the machines like Zimmer also has a manual. Uh, Now it's auto what? Torsion, centration. Okay. So that's it. J&J Alita that we have, it is there also. Next thing is to do it like with the eye design to do it automatic. But just now it's you have to do it manually. So that is something very important that you have. But in any case, despite not having a cyclotorsion, you can do a marking in Visumax also and see before you dock, and you can actually move that and see that it is, so you can turn the head and do the cyclotorsion compensation.
Okay, thank you, sir.
It's our pleasure to now invite Dr. Bharti sir. Sir is the Bhishma Pitama of refractive surgery. He was one of the first pioneers of refractive surgery in Delhi and has a tremendous experience running into perhaps not 1,000 but lakhs of patients. He is the founder and the chairman of Bharti Eye Foundation. And sir, it is a privilege to have you with us today. Sir will be speaking on clear lens extraction, bioptics and trioptics.
Thank you, Ritika, for inviting me, and Maipal for inviting me for this talk. Um, it's a wonderful program. I can see it's a program for learning, and I think it's very nice to be part of this program today. I'll be talking on pushing the limits, clear lens extraction, bioptics, and trioptics. Okay. So here we are. I'll be taking you back to the complete spectrum of the refractive surgery. There are keratorefractive surgery, the incisional, which we started with long back, almost 30 years, 35 years ago, with radial keratotomy, astigmatic keratotomy, LRIs and OCCI, which are still practiced. And then corneal refractive procedures, the keratomiliosis, freeze and non-freeze both, epikeratophakia and automated lamellar keratoplasty. So out of these, I have practiced radial and astigmatic keratotomy and still continuing with LRI and OCCI. And also the started with ALK in my early days, and then used that keratome for my LASIK procedure at later point in time. Laser ablation corneal procedures are PRK, LASIK, LASIK, EpiLASIK, C-LASIK. As my previous speakers have already spoken all these procedures, and then the procedures which were given up in due course of time, the conductive keratoplasty and thermal laser keratoplasty. And now we have already come to a situation where we are using the corneal implants like Intacs, but not the intracorneal CL. And lens-based procedures, the phakic IOL, the refractive lens exchange. And now my topic is bioptics and trioptics besides the refractive lens exchange, the clear lens extraction. And these are the procedures which will be, I'll be discussing. So for any refractive procedures, the contraindications, the eye problems which will be, you should be careful about and not do anything in all these procedures at all in all these cases is herpes zoster, glaucoma, dry eye keratoconjunctivitis sicca, keratitis and lid disorders, abnormal corneal shape, contact lens induced corneal pathology and ectatic conditions like conus, globus, PMD, And of course, the uveitis, the lens changes in the eye, myopic degenerations, diabetic retinopathy, retinal detachment, etc. Because these conditions will make the things worse in all these cases. Radial and astigmatic keratotomy was started by Fyodorov, and they are good for 4 to 6 diopter of sphere and 1 to 4 diopter of cylinder. And for correction of cylindrical power, the incision should be on perpendicular to the steep meridian, and that the correction level is pretty accurate and high in immediate terms. And it is only after about maybe 15 to 20 years that you see the hyperopic drift and shift at a later point in time. But first 20 years, it is an excellent result which you can see. Then came the excimer lasers, which is 193 wavelength, micron wavelength, and it has got high absorption in cornea. This has sufficient energy to break carbon and carbon nitrogen bonds, rupturing collagen into small fragments, and very discrete volume of tissue is removed, and ablation per pulse is about 0.1 to 0.5 microns. So the accuracy of this procedure is also pretty accurate. The femtosecond laser is infrared wave 1053 nanomicron, and each pulse of focused light lasts about 10 to the power of minus 15 seconds, which is 500 to 800 femtoseconds, and causes photo disruption, as we have already discussed. It causes plasma formation and causes cavitation bubbles along with that. And this cavitation bubble causes separation of the tissue plane, which we have been talking all along on during this earlier talks. So the procedures which are available to us are PRK, the photorefractive keratectomy. This is treatment for myopia, hypermetropia, and astigmatism. Cornea is reshaped with excimer laser, and the need is to remove the epithelium manual or in the PTK mode, and also trans PRK, which is actually PTK followed by PRK. It ablates the Bowman's layer and stroma, and that is why there is some amount of healing by fibrosis, and that is why you need some anti-metabolite like mitomycin C, which is 0.1 to 0.2% for depending on what is your protocol, 30 seconds to 1 minute. And this will take care of the reticular haze which develops at a later point in time. So patient selection, the 4-5 criteria which are very important is the age at least 18 or above, stable refraction for at least 1 year, no corneal disease, corneal thickness of 490 micron or more. This was basically for LASIK, but now I think this is the standard protocol. And contact lens to be discontinued for at least 5 to 7 days. The flap which are made for LASIK is could be microkeratome, like ALK, which used to make a linear movement on the surface of the eye to make a flap with a hinge on either on the nasal side, or a rotational or a pendular microkeratome, which was after the linear keratomes were available. After that, this rotational or pendular keratomes came. And then the femto bladeless flap, which is very much more accurate by the size, the thickness, the uniformity, and the flaps with the microkeratome were like meniscus. They were thinner in the center, thicker in the periphery. So that was another factor where the flap thickness were irregular and was cutting more thickness in the periphery. And that is why the ectasia was more common as compared to the femto, which is a bladeless flap. Now, couple of things like advantages of LASIK over PRK is LASIK has no or minimal post-op pain. The visual recovery is faster, and that is what is normally called wow factor, where most of the time which you can correct with the LASIK, and or any excimer laser procedure for that matter. And that is where the limitation of the laser vision correction is, leading us to add some or more procedures in other thing. LASIK or laser subepithelial keratomiliosis was devised or designed by Massimo Cameleon in 1999. The epithelium removal by alcohol by making the cells degenerate or dead, and it has safety like PRK, but the advantage over PRK was it is slightly less painful and can be done in thinner corneas, and of course there were no flap related complications and little less dry eye as compared to LASIK. LASIK was started later with the epikeratomes, which was started by Palikaris in 2003. It is more or less like LASIK. The only thing is the flap was created with the epikeratome, and that is why the pain and other things and the healing were much better as compared to the PRK, where epithelium was completely removed. Customized LASIK is, as we have already heard the previous speakers about topography guided and now very popularly called Contura vision, is the topographic guided ablation, which is available in the previous machines for last at least 20 years, but the new machines come with the new fancy terminologies, and this is what is now happening, because the topography guided machine in my system is what always there some 22-23 years ago also, and we continued with the topo or wavefront guided ablation. The machine had so many choices. Now wavefront guided, you all know there are wavefront abrometers, which are multiple abrometers are available, Hartmann Shack or Scherning or ray tracing, and what I am using is a OPD scan by NIDEC, which is pretty accurate and a fantastic abrometer. Now the other techniques or technologies which are available is phakic IOL. The most common what is used is ICL, which can correct myopia up to 8 diopters and hyperopia up to 10 diopters. And especially in all those cases where the cornea is not sufficient for laser treatment, and also in keratoconus, after you have stabilized the progression of keratoconus, you can correct the refractive error, residual refractive error with the ICL. In myopic eyes, the AC depth should be more than 2.8 millimeter, and hyperopic eyes it should be more than 2.9. Since it is the anterior chamber surgery, so the specular count is very important, and it should be more than 2250 cells per square millimeter. And angle, because the lens is fixed in the angle, it has to be more than 30 degrees, so that there is no possibility of narrow angle glaucoma developing after the ICL implantation. And of course, no ocular pathology for any intraocular surgery, which is meant for only just for correction of the refraction. Advantage of the phakic IOL, the most important advantage as I can see is it is reversible. The quality of vision is very high, and of course it is very good for bioptics. It is safe and predictable. The calculations are very, very accurate. There are other lens-based surgeries, clear lens extraction or refractive lens exchange for correction of high myopia or high hypermetropia. Myopia more than -18 diopter can be corrected, which is actually a limit for ICL, so you can correct myopia more than -18 diopter or hyperopia over 6 diopters, and especially the retinal complications in high myopia should be under, you should look at the eyes with all the degenerations, peripheral degenerations. Risk of RD is quoted as 1.5 to 8.1% in patients with the lens-based surgery, and more with the axial length of more than 30 millimeter, and more after the YAG capsulotomy in all these cases. And the other factor which should be considered is that when you do a lens-based surgery, there is loss of accommodation in a young person, and that's why you either need to do a multifocal IOL, but there associated, complications of the multifocal IOL in a young patient. So bioptics can be with RK or astigmatic keratotomy. We can do RK or AK over LASIK or PRK or LASIK or cataract surgery in ICL. We can, if the minor corrections are required, we can do RK or AK in all these cases, especially after cataract surgery in ICL. It can be practiced for a correction of up to, 2 or 3 diopters, which is very, very accurate. And in elderly patients, where after you have done a cataract surgery, the possibility of doing an intraocular surgery to remove the IOL and reimplant a new power IOL, sometimes a little dicey. So in those cases, RK or other things are possible, and this is one possibility with bioptics. And bioptics is basically, if it is not possible to correct ametropia fully with a single procedure, a combination of 2 procedures can achieve emetropia, and that is what is bioptics. And it can be practiced in any myopia more than -7 or hypermetropia over 4 diopters. Extreme degree of myopia or hypermetropia are treated better with combination of lens and laser. After refractive error, after post laser or multifocal IOL or a phakic IOL or post lens exchange, refractive lens exchange, it's a very good option. So all these things where you can combine the 2 procedures to achieve a total emetropia is a good option. Intacs, we have already discussed, Dr. Ritika has discussed, and I'll come to that possibility of doing bioptics or trioptics with the intrastromal corneal rings. And the lens-based surgery, the ICL can be implanted over the IOL already done if you want to do astigmatic correction. And of course, these days you have customized IOL available beyond the range, which is -10 to +40. But you can always, if you have a patient who was done earlier and now has a myopia of 1 or maybe 6 or 7 diopters, when in the childhood the child had the cataract surgery done, you can implant a piggyback lens or ICL, which I have done. And I think I'll omit this video for the time being and continue. So limits of correction, as I have said, it is like all these PRK is -6 to +4, LASIK is -8 to +6, ICL is -18 to +6, and astigmatism up to 6 diopters. Clear lens extraction mostly is good for -18 or more, and refractive lens exchange for -30 to +10 diopters, and Intacs mostly within 2 to 3 diopters, and up to cylinder up to -6 very comfortably are corrected with the ICRS. So these, you can correct and then go forward and use some other procedure for anything which you need to do for more than this correction. So the bioptics is combination of all these things, the refractive lens exchange you have done, and then you can do a PRK or LASIK or ICL or PRK LASIK combo. Intacs with ICL, like you have done Intacs for a keratoconus, and then correct residual astigmatism or a myopia with the ICL, and Intacs with laser or combination with IOL or piggyback IOL or ICL or Sulcoflex, and IOL with PRK or LASIK. But the fact, the important thing is, if LASIK is planned as a final corrective procedure, the flap should be created before the first procedure, because flap creation in a eye which has undergone a cataract surgery or a IOL based or lens based surgery, there is a possibility of change in refraction after flap creation, and also CME, especially after CLE or RLE. So I normally create a flap beforehand, understanding that we'll need a laser correction, and then lift the flap at a later point in time after 1.5 to 2 months, and do a laser correction, lifting the flap later. So trioptics I have done in few cases, which is after C3R and Intacs together doing in one sitting. I have done ICL, and in all those cases where ICL has also not been able to correct the refraction fully, a PRK over and above all these cases is also possible, and you can use trioptics in all these cases like this. Thank you very much.
Thank you, sir, for a very comprehensive overview. Any questions for sir? May I now invite Dr. C.V. Gopal Raju, sir, to talk to us about the retinal considerations in refractive surgery. We all know that most commonly we are treating myopia, and myopia comes with myopic fundus and its concomitant retinal issues. So, sir, over to you.
Thank you. First of all, I thank Professor Mahipal Sachdev sir. He is my teacher, and I am very lucky to be a part of this faculty. And also thank the entire team of the CFS for giving this opportunity, and also especially Rolika for organizing that meeting. See, the most okay. See, as such, when we were becoming a super specialist and a specialist, we are ignoring, we are limiting mainly to the eye, and we are ignoring the entire body. Similarly, when you become a more super specialist, we are more confined to the particular part of the eye. Like if you are a cornea specialist, then you will ignore the retina, and then if you are a refractive surgeon, then we ignore the other things. But we should treat the whole eye holistically, and especially unless you have a proper thorough preoperative examination, whatever best the surgery you will do, if you miss some of the retinal conditions, then the patient will be terribly unhappy, or sometimes it may end up in the medical legal problems and no financial interest. This is the overall overview of the refractive surgery, which Dr. Bharti has nicely explained. And mainly corneal or implants are the lens based. And then out of this, retinal considerations are most important except the PRK. All the other procedures will have either directly or indirectly or concomitant retinal changes, which we all should be aware. So why we should look into the retina before any refractive surgery? Retinal degenerations and other lesions are more common in the eyes, especially with myopes. And refractive surgery can have an influence on the retina during the or after the procedures. And patients also can attribute anything that happens following the refractive surgery, even that might have happened even without surgery also, but still they attribute to the surgery. This is the problem with all surgical branches. Once if you touch or alter any surgery, lifelong whatever happens, they will always attribute towards the surgery. That is the main difference between a physician and a surgeon. And then the main why we should look into means the peripheral retinal degenerations are common in myopes, and studies have shown the higher prevalence with the higher the power. And the common things are the lattice, snail track, and all these degenerations, and also the posterior vitreous detachment, which is more common in myopes, and even that presents even much younger age in myopes. These are all this is a classification of the retinal lesions where we will treat, where you don't require any active intervention. are the predisposing lesions where we should treat. So these are some of the lesions like microcystoid changes, paving stone, then snowflake, and then snail track degenerations where it doesn't require any much intervention. And this is again all the lesions where we don't treat. If you want to click the things, this is the best table where we treat. These are the definite lesions where one should intervene. Even if you treat or don't treat, or if you are doing a refractive surgery or not, so we should intervene to prevent the retinal detachment. Especially lattice degeneration, if there is no hole and you are not doing a refractive surgery, then we don't have to treat. If it is, then you need follow-up and then treatment. Apart from this concomitant retinal degenerations, how the refractive surgery is going to influence the retinal degenerations, why we should prophylactically treat if you are undergoing retinal refractive, if you are treat the retina when you are undergoing refractive surgery. In LASIK, especially when you are applying the suction ring, it raises the intraocular pressure suddenly, and then when you decompress, and then suddenly it lowers. So that causes the changes in the vitreous macular interface, and then that can cause the changes in the retina. And also another hypothesis is the laser can create a shock wave that's very rare, and then all these interfaces that can lead to changes. Many patients complaining of increasing in the floaters following the LASIK surgery. That is mainly because of the induced PVD. There are studies which have proved that the induction of the PVD is more following the refractive surgery. And even in the modern femtosecond LASIK, where the incidence of PVD occurrence is high, because the amount, the duration of the suction in the femtosecond lasers is more, and then that may be the one of the reason. Even though the suction pressure is less, but the duration is more, that can cause the PVD. So retinal examination, so that's the reason why they all should undergo thorough retinal examination both before and after the surgery. Even after the surgery, in the follow-up also, they should routinely undergo a mandatory retinal examination. Like suppose if a non-myope, how they undergo yearly retinal examination, fundus examination, that same thing should continue even after the refractive surgery. And prophylactic treatment should be done in case of presence of the lesions. This is a nice table where you will intervene. Mainly the lesion, all symptomatic and asymptomatic horseshoe tears, operculated holes, and lattice degeneration with retinal holes, they should be treated promptly. And all symptomatic lattice degenerations without retinal holes or atrophic holes may be recommended for treatment. And then all asymptomatic lattice degeneration without retinal holes, pigmented lattice degeneration and atrophic holes, they can be observed, they need not be treated. And then eyes with atrophic holes, lattice degeneration, where the fellow eyes has already developed a retinal degeneration, then that can be considered for the treatment. This is the general recommendation and treatment strategy in retinal lesions when you are a patient undergoing a refractive surgery. This is the overall flow chart. Any patient should undergo a detailed retinal examination. Then if there is a lesion, then take the help of the retina specialist. Then like earlier we covered, the all treatable lesions should be treated, and non-treatable they can proceed and plan for the refractive surgery. And then following the refractive surgery, retinal re-examination as early as 2 weeks. If you have a doubt, then flashes and floaters, if they are present, they require again a detailed retinal examination. On a long-term follow-up, again they need a regular retinal examination. These are some of the surprises they can happen following the retinal surgery. This is a large hole with the retinal detachment. The treatment is similar to how a retinal detachment in a non-operated eye, refractive surgery eye. The surgical management like pneumoretinopathy, I think you already covered in earlier sessions, or in the pars plana vitrectomy. And this is another example of retinal lattice degeneration with holes. If untreated, they can cause a retinal detachment. And especially in young patients, where the major drawback is, after even if you do a good retinal surgery, it causes the increase in the nuclear sclerosis, and then change in the refractive error, and all these challenges will be there. So next comes to that is all about the mainly corneal refractive surgeries. There are different set of challenges in case of the intraocular implants and then the lens-based surgery. And all the earlier precautions should be continued and followed. In addition to that, myopia, all these same, but in addition to that, there is a foveal or macular related complications can be there. So all these patients needs a thorough macular evaluation, if necessary OCT and then the FFA. And we have to first ascertain the visual potential, and then the intraocular inflammation is another main culprit that can cause the macular changes. Like Dr. Bharti has already covered, that the cystoid macular edema can occur following the implants and intraocular surgeries. And even the CNVM can happen, which is again a risk factor in all high myopes. All these things should be treated as usual. So in summary, that retinal considerations in refractive surgery are most important. Retinal lesions are common in myopes. Refractive surgery can influence the lesion's behavior, and proper preoperative workup and prophylactic treatment is essential. Preparing the patient for the future consequences is also most important. The post-refractive surgery, all patients require regular retinal examination. Any retinal event, the management is similar to the normal case. The implications are more in this refractive surgery cases, especially when you have operated on him. Thank you very much.
Thank you, sir. Any questions for sir?
Yeah, that is if you are doing a laser barrage, minimum is the 2 weeks. 2 weeks is the minimum waiting time, so that the adhesion will develop and then the scar will develop. Then we can proceed for the surgery. Yes, we need to again dilate and then see whether the entire lesion is properly covered, or if there is any skip lesions, or the proper reaction has developed or not. We have to ascertain before proceeding for the refractive surgery. Thank you, madam.
Thank you, sir. So I now like to invite Dr. Raghav for the refractive quiz. Raghav, we don't have prizes, we are hypoglycemic. Raghav has prizes. Raghav has prizes.
These are the gifts, right?
Nice.
Okay, so I think I'm going to start with the quiz now. So it's going to be an open-ended quiz. Whoever knows the answer, please raise your hand. First to raise your hands will be able to answer, right? There could be multiple answers to one question. The more you answer, the more gifts you'll get, of course. Okay, so question number 1. So what is the clinical diagnosis? No,
ICL के
there is
साथ
something
क्या है?
else along with the ICL. Look at the lower picture.
ICL के साथ क्या दिख रहा है?
Okay. So it's post ICL cataract. So what type?
No prizes for.
Who answer? Who raise your hands first? Okay. Good. Okay.
Okay, it is an IPC.
Okay, so the type of faking IOL is wrong. It's not an ICL. Okay, so what is the cause of such a cataract? Raise your hand first. Low volt and. Okay, so that will cause a low volt. If you invert the ICL, call it low volt. Okay, I'll give that to you. Low volt, mechanical trauma, and reduced nutrition to the lens.
So how will you make out that this is not an ICL? What is that central hole called?
Over there.
Yeah.
Okay, so next question. Yeah, to him.
Okay, next question. Sorry.
Yes.
Yeah.
Yes.
And inflammation. Inflammation and retained viscoelastic. And how will you do the biometry for this patient?
Ma'am, we're coming to that.
Oh,
We're coming to that.
Sorry. I thought you were over.
Okay, so of course, this is the central flow. So the ICL has a central small hole that helps in evacuation of the visco. So what is the size of this center flow? Raise your hands.
Yeah,
Raise
yeah.
your hands.
उसने पढ़ा हुआ है. She said it right.
She's right. 360 micron.
Why is the size chosen like 360? So it was chosen to not have visual disturbances, yet allow the flow of aqueous. So as to the point of the central flow is to prevent not only pupillary block but allow better nutrition for the lens so that the aqueous flows. Intraoperatively, it is useful to remove visco.
So the management of this only Maypal sir can show us. So he's going to show us.
Biometry तो बताया नहीं राघव.
हाँ जी मैम.
Biometry कैसे करते हैं?
आ रहा है. I got part of it. So of course you go through the main wound, and the lens itself is very soft, and it comes out through the main port. That's it. Then do a cataract surgery, and then IOL is placed. Okay, I'll move on. Okay, so double or nothing for this. For answering this, you get 2 gifts or 2 chocolates. So, Ritika ma'am's question. So, what is the special biometry formula you use for IOL calculation? Yes. Okay, that's wrong. Someone else? No, for the first question you got the
Negative
gift.
marking because of lack of chocolates.
Anyone else? No, you raise your hand first. Okay, I'm sorry. Ma'am, you can answer. So there is no
special.
There is no special biometry formula used. You
The
don't require to change
ICL
the
does not.
biometry.
The ICL does not interfere with biometry. Yeah.
Yes. So your biometry, that is your keratometry, and your length, action length are not changing at all.
Expand series. Lolika mic. Raghav, next.
Okay, next question. So I'm starting, of course, I gave a talk on this. So name the procedure. Raise your hands.
इसकी chocolate नहीं
Okay,
मिलेगी.
yes, you. Okay. When was it first described? Not published, described.
All 3 questions get the
Okay, give me a decade. I don't see hands. Hands. I'm getting the right answer. Okay, 98. I'll give it to you. 1998. Okay, fine. Dresden. I think that.
Double or nothing.
Okay, so double or nothing. Can someone describe the Dresden Protocol for me? You can try. No one? Okay, please.
Firstly, we remove epithelium with the use of either hockey stick or alcohol or PRK. Then
Not PRK, we just remove the epithelium.
yes. Then we put 1 drop of riboflavin every 3 minutes over 30 minutes.
Okay.
Then after that we measure intraoperative central corneal thickness,
Which should be?
which should be more than 400
Okay.
micron. Then we apply ultraviolet A radiation
Okay.
for with there are various energy should be
Okay, for how long?
either it would be
The original Dresden
Original
Protocol.
protocol.
There's only one answer.
3 megawatt per centimeter square for
Milliwatt.
No. 3 milliwatts.
3 milliwatt for a time period of 30
minutes.
minutes.
I'll give that to you. Good. Right answer.
Only two things you can add. In the Dresden Protocol, they use riboflavin with 20% dextran. Now you
1% riboflavin
with 20% dextran. Now you get riboflavin with HPMC also. So dextran is not necessary to use. And at that time, they used to look at the AC for yellowish flare to make sure that the penetration of riboflavin is enough. That is one step that we have almost abandoned now.
Yes, ma'am. Okay, so now the next question is a bit complex. I will consider it complex. If you can answer, probably, do we have a bigger gift, Rolika? Do we have a better and bigger gift than chocolates?
How many chocolates?
Okay, so what do you see?
Oh.
Raise your hands. I got the right answer. Yes? Yes. Okay. So what is the mechanism of action? And what is it used for people who don't know? What is it?
इसकी तो
Yes. Yes. What is the mechanism of action? Mechanism of action? I'll give the marks to you, just extra marks for this. What's the mechanism of action? So you're creating a pinhole effect to increase the depth of focus. Okay, right. Okay, and now, do you know the central aperture? .6 millimeters. Okay, I'll give the answer to you though. Okay, next question. So, what's the imaging modality? No, the modality.
No.
Both answers are fine. Which one? Who's answering? I heard the answer, but I need someone to give the gift to.
They have had enough of chocolate.
Okay. Okay, someone else, please.
They're high on sugar.
Okay, I heard pentagram, I heard tomography. So both are right. It's a pentagram. So, okay. So what is a possible complication with a microkeratome LASIK? If you're making a flap with a microkeratome, what is the complication that is more specific to a blade LASIK? Okay, more than an incomplete
Look
flap.
at the keratometry.
it's a flatter cornea.
It's a flat cornea.
नहीं.
उसका उल्टा बोल दो ना.
Free flap. Free flap. So you'll have no hinge, you'll have the flap which is free floating, and that is a catastrophic complication, which again, my Palsa will show us how to manage.
So ideally, the answer here should be Schimflug imaging, huh? For the exams. And that is the toughest spelling too for you to get right.
Schimflug. Yes. So yes, because the pentacam is based on Schimflug imaging. Yes. So this is the management. This was a case we had quite a while back, my Palsa's case. So you are teaching us how to manage a free clap. So as you can see, the keratome is moving, and then as soon as you move the keratome, you can see the stromal bed. There is no flap on top of the stromal surface, and you see there's a flap inside the blade. So it's very important to mark your cornea preoperatively so that you know the orientation of the flap. If you don't, you can have irregular astigmatism. So if you know the orientation, the flap is placed.
You also have to know which side is up.
Yes.
Okay, so the epithelium side has to be up. How will you distinguish between the epithelium and the stromal side? जल्दी बोलो, वीडियो खत्म हो रहा है. ये देखो दिख रहा है. This is what side? Is this epithelium or this is stromal?
Yes. Now it's being turned.
And if you're still in doubt, you can actually scrape it off. The epithelium gets scraped off. The stroma doesn't get scraped off.
And just disclaimer, it looks very easy to see. If someone ever faces it, you will start vibrating. Anyway, you place a contact lens and patient does good. Okay, so now what is a possible cause of a patient who is having repeated ICL rotations? You have a toric ICL, small size or small.
Yeah.
So what option to choose? Low volt.
Small
Low volt.
size is called, yeah.
Okay, because if you have a low volt, that is you have
Small
an
size.
undersized ICL, so your ICL can rotate. All three other options are wrong, because if you have an upside down ICL or a high volt, you will have a shallow anterior chamber. You won't have the ICL rotating. So Rolika, that's your answer. Yeah.
Which one?
Okay, so now this is also a little tough. Identify this modality. Okay. Okay, and I'm forgetting, can you give me the full form? Okay, so it's corneal visualization with ST stands for Scheimpflug tomography. Okay, so what does it measure? Corneal biomechanics, yes. So I'm going to show you a video of how a normal cornea vis-a-vis that of a keratoconic cornea. So if you see,
Let them guess, Raghav. Which one
so
is?
this is a normal cornea. You can see how it goes down and it comes up. But if you look at a keratoconic cornea, it stays down for a much longer duration and comes back much slowly. It is less stiffer. I'll show it to you again. We can see them side by side. So compare. See how fast a normal cornea comes back up? Okay. So identify the diagnostic modality used here.
ASOCT.
ASOCT, right. Okay. And of course, simple question, what is this space called? Vault. And what is the ideal range for the vault? 250 to 750. 250 to 750 is the ideal range. Okay.
When you see it on the slit lamp, what do you use as a reference to guesstimate the vault?
What is the right multiplication factor? How much corneal thickness? One corneal
corneal
thickness, 2, 3, 4, 5. What is the average corneal thickness, average Indian corneal thickness?
500.
Okay, so 520. So how many? 1 to 1.5 times is the right answer. 1 to 1.5 times your corneal thickness. Okay, so now can you diagnose this? What is shown in this pentacam? Perfect, good answer. Perfect, yes. This is post-myopic ablation. And what higher order aberration would it cause? Spherical aberration. There's no, yeah. Okay, so we have gifts left? Yes.
अब मुश्किल सवाल पूछ रहा है, अब
Okay,
chocolate नहीं है.
again now coming back to Ritika ma'am's talk. Yes, yes. Okay, do we have more left?
बहुत.
Yes. Okay, so 2 more questions. Identify? Okay, you got the answer, right? It's maybe someone else. Intacs, yes. Okay, and what is the mechanism of action? Yes. So we are having an arc shortening effect, right? So basically, like ma'am showed, like a hammock, we are shortening the arc.
Where am I supposed to get this?
Next to her. Yes. Okay, last question now. So name the finding. This is after a PRK or a surface ablation. Haze. Okay, fine. How can we prevent haze? Mitomycin, yes.
Mitomycin.
Antimetabolites given during the procedure help us to prevent haze. Again, one more chocolate here.
And what will you ask in the history taking when you're doing a PRK? History of keloid.
Yes.
People who have keloid should not be taken up for PRK. They will develop haze. And you also advise them to wear sunglasses and avoid excessive
Ultraviolet
sun.
protection. Yes. That's it. Thank you.
Do we have, Rolika, do we have the, did you announce the polish staple? Or that will be done later?
Sir will announce that. Sir will announce that. So I just want to tell you guys a few things before we part ways. So basically the concepts, many of you have been asking for the handouts. So handouts are not really hard copies that can be handed over to you. Handouts are something that we will be uploading, right? So I've been collecting the handouts with me. Just give me some time. I will be uploading them on the link that is there. These handouts have been collected over the past few years. So what data you have is already very precious. If we start giving out physical handouts, like, or hard copies, it will be very difficult for you to carry it because everybody comes from different cities. They have been traveling, okay? And it's unnecessary wastage of paper, correct? So handouts are never given in hard copy. They're always a soft copy handouts. It has been a trend forever, okay? Probably there was a confusion, so I'm clarifying to you. Okay, and second thing I want to pass on a message is everybody has been asking about how important is fellowship. I'll just brief it in one thing is that whatever you learn in your MBBS is like say X amount in 5 years, all right? Then when you move on to your MS or like postgrad or DNB, that is the time when you will be reading 3X in 3 years. All right, and in fellowship, you will be reading 10x in 1 year. So you can imagine what you have to do. So it's the essence of everything. The gradation keeps increasing, and the importance keeps increasing, and also the spectrum gets narrowed up. Okay, so please focus on your fellowship, and that is the most sacred time, and give it your 100%. Your city does not matter about how much fun is there in that particular city. Okay, you just go from the hospital to your work to home and come back. If you're doing that, then you're doing justice to it, okay? So over to Mahipal sir for the closing remarks. And thank you, all of you, for actually making it a very wonderful event and a wonderful experience for us to remember. So over to you.
I think, thank you, Rolika, and obviously we still have people here till the very end. And it's always been a pleasure having postgraduates with us. We've obviously asked you to fill up certain forms, and we have seen. So the minimum gain of a person in self-assessment that I have seen is 20 to 30%. So that's what most of you have said, that if you are 50, you have come to 70. So I think that's something that one has achieved significantly. But what is very important, that you have all been great, and the hunger for learning has been fantastic. So keep up your thirst for wanting to always learn and be academically sound. There's something which is always a dilemma. Some people say it should be for 2 weeks, and some people say it should be for 3 days. So we really don't know what to do. But that's, I don't know, that's what it is. Would anyone wish to say something? The bright girl here. How did you feel? Anything? She's selected for fellowship, okay. But she's in Forge, no? That's all.
So on behalf of all of us, I'm sure whatever I feel right now, exactly that is what everybody is feeling. It was an extremely exhaustive 5-6 days of our course at iFocus. All this while to have a physical course, which we were not able to have because of COVID, but to be physically present, see all of you, like there are times when we felt that, oh, there's going to be an inspirational lecture, let's just miss it because we just want to come for academic sessions. But to see what has been done by all of you who have, gone through the same phases as us and achieved what you have achieved, I think that is an extremely important inspiration. And like you said, I'm from the armed forces, so it always feels, oh, will I be able to join a fellowship outside, maybe at CFS? So that thing is in my mind, and I'm sure if it's hitting me hard, I'm sure it's hitting all of us hard as well. So which is why a lot of people are approaching you for fellowship. And as far as the duration of the course is concerned, I think to have it as 8 to 8 is already, there's so much to learn, I think. And like you said, people are going into hypoglycemia, taking frequent breaks, the entire arrangement for lunch, and just to make sure that everybody is being answered, whatever the queries are towards the end. And you got the best of people to teach us, sir, I think. So that has been an amazing experience, and we're going to remember it for life, and I hope this continues. And like sir said, previously, I think Ramani sir had said that it should be probably not renamed, but it can be used as a synonym, that it should be called as iFocus as well as iFest, because it indeed was a festival for all of us. So thank you so much.
Young boy, you know a lot of refractive surgery for sure.
So my area of interest is cornea
Great.
only because I like to pursue it in the future. So I believe that the sessions were exhaustive, but there were a lot of information in all of them. And more than knowing new things, like I will agree with the people saying 20% we have increased our knowledge. But it was like we also revised the 50% we had, and we didn't know that we had or not. So when we go through all the sessions, our teachers, our speakers say, we revise everything, and then it is like, now I will remember it when I need to apply in the clinic.
Great. You want to say something?
It was a very good 5 days. Like already mentioned, it was a very good revision for especially the exam going PG to go through all the topics that we have covered in such a short time, and by such eminent speakers as well, and also update some of the knowledge, listen to some of the more recent updates that probably haven't been exposed to in our MS. So it was a great time, a lot of fun. Even the cultural events were amazing. It was a nice time to interact with PGs and from other parts of India and staff as well.
Good. So I hope all of you made good friends and you carry good memories. I think it's been always fantastic to host you. Unfortunately, my only regret is that we don't get too many suggestions how to improve. So that's something I have seen lots of them, except for the time and people getting hypoglycemic. I think all of you have rated the presentations, the faculty, etc., to great heights. And I think what is a common thread in almost all of us is that we love to teach and give back to the next gen to take ophthalmology to the very brightest future. And as it is, I think Indian ophthalmology is really a shining star today in the world of ophthalmology. So kudos to all of you, and hope you do well in your careers and do better and better than what has been done by others. And I think finally, I'll just wish to say that we always have a big apple. So this is not the Adam and Eve apple, but this is the shining apple that we give to the best teacher. So any guesses?
Come on.
Yeah, so that's always a given. He's left, so I think year after year it goes to Santosh and over. He's what you have voted or what you have said as the best, and next comes Rashmin Gandhi. So big round of applause for them. So that's the big apple.
So,
And- sorry.
may I add something, sir?
Sure.
I just want to add one more thing to you guys, that many people asked about the competitive sessions being irrelevant. Let me tell you, it adds to your CV. Like when you go to your conferences, most of the times the presenters you're competing with are either fellows or somebody else, right? But or somebody higher in authority. But when you compete, when you take a certificate from here and when you go and add to your CV, it helps you. These competitive sessions make you come out and, talk on this stage, and they make your fear go away. And I know that the sessions can be really too much. I have been on the other side in 2020. I was there. It was very tired, I agree. But it gives you a kick. Okay, it gives you a kick to read more. These 7 days nobody can extensively teach you on any topic. You will get more saturated if the topics are kept lengthy. Okay, so when you get brief notes of every single topic, you go back and you're like, okay, I need to read because I don't know much about it. And that's the whole purpose of it.
Thank you, Rolika, and thank you, everybody. Thank you for putting up such a good show. Negi is there, he helped, Murli is there, and all the audiovisual people, and obviously all the faculty, and above all of you who have come. So keep in touch, do well, and give us your suggestions to keep improving, and I assure you this show will keep on going every year. Thank you. One second. Just give.
On behalf of all the faculty, actually, I would like to thank you, sir, and team iFocus, Santosh Anwar, sir, Dr. Rashmin Gandhi, sir, Dr. Rolika, for Dr. Ritika, Dr. Alka, ma'am, everybody for giving us such a wonderful opportunity. And I think all the students and even all of us also have learned so much along with them. Thank you so much once again, and a big round of applause to them.
Thank you. So safe travels back. Bye-bye.